كتفطري هنا هو تنفس. ها علاش اصاحبي كتخسر الهضره؟ حقا مازال خصك دير مع واحد اللعيبه سيكولار يرفض دير لي شي حاجه. انا راه ما عندي حتى جوج قسمين في البارك والله.
No, I'm in the map. and 20, let's say 2020, I went that sister send that wound to one of our senior sisters at US. They now told me to go for tests. I went to Ikeja General Hospital to go and do tests. I wait for the test for almost 3 months before the result come out. When they declared to me that I have cancer, they don't even tell me. They say I should bring my people. When I bring my people, they declared to me that I have cancer on one right breast cancer. That day, I think that is that day I will leave this earth. My people start crying. Somebody direct us to one yaba that those imported drugs. I went there, the man say he said drugs for me 600,000. I say me, oh, I don't hear the day where I won't die, where I won't see money to do this thing. I went back. So when my schoolmates, my classmates, I told some like 3 people out of them, say, see my problem. They say, we used to do meeting. They now raise the issue in the meeting. So these people contribute money for me. I came to the cancer center here. I owe 10,000 naira. When I reached there, they told me that consultant is 50,000 naira to collect card. I cried that day, say, so this is the end of my enemy. When I went back, I told my school classmates, they now contribute money for me to go and collect the card and do the test that time. That is how they start follow me up with the sickness. My school classmates, they introduced that matter to those old student association. They now announce that they don't even mention my name. All of them, they contribute money for me. Our president is one of my brother, CR Williams Daudu. He is the person that raised that amount with 300,000, and people they contribute for me. They contribute like I start the treatment. I collect chemo 7. On this processing that I'm coming for the chemo, one of my brother Tunde used to carry me come. All my sisters and brother Papa Yawoni, they support me with money, and Timoy, all of them, they are just supporting me to come for the chemo. I collect 7 chemo. As I'm collecting this chemo, people are now sending picture and message to me, don't collect chemo. Chemo is killing people. I will shock. I will be crying, say, I want to die in it. But for the God glory, I collect the 7 chemo. I pass a lot. At times inside house, my this thing will just go. I will not be able to carry myself. I just manage. I believe that it's not cancer is killing people, it's sickness that you don't carry everything to body. It's the thing that is killing. When I start collecting treatment for this cancer center, my mind calm down that yes, I'm alive. I know that I will not die. My people, it's not sickness that's killing people, it's money. It's money. I used to beg up and down, beg to eat, beg to buy drugs, sending message to kind of people. And my kind people, they support me. Nobody that I will send message to. If they cannot give me 10,000 naira, they will give me 5,000 naira. They support me with money. So that is, they give me courage and back me up. Say they don't want me to die. One of my sister that I used to, he have challenges in my town woman. Around that time that I'm collecting the chemo, the woman is not, she told me that he cannot collect chemo, but I'm collecting chemo. The woman pass out last month. It's today that I carry the body to our town to go and bury the woman. I thank God for my life. My advice to people is that don't give up. Any situation that you are, don't give up at all. Believe on your God. Believe on your God. And my Dr. Adegboyega, used to tell me that do act as they say you should do. Ẹ sá bí ológun ṣe ni kò sá. I used to follow the word. Say that woman say do as they say you should do. I thank God for my life. I thank God for my life. I don't know where I can start. Now I see the on treatment. I'm begging up and down to collect the radiotherapy, and the radiotherapy cost me 1.5 million and some tests and they don't base me on drugs for 5 years that will be taking. My people, I just want to take my experience to tell you people that anything that happen to you, don't give up. Don't give up. Just move forward. Move forward. Don't see yourself like you are not more again. Tell that I believe that what God does not do or cannot do does not exist. I believe that anything that you are doing, believe on your God and be exposed to people. Be shared with people. Let people know your desire and let people know your problem that they can support you. If say I close my mouth, maybe I cannot be able to talk to this afternoon. I thank God for my life and thank God for my people and people that support me. I still need help because I still wan collect radiotherapy now. I still on treatment. So I take my own experience to tell my people that what money is cost this life is many. For this cancer center, they are trying their best. They are just doctors that are just trying their best. It's God that can do something. I know that they are trying their best. So I want you people to learn from me. Don't give up. Maybe you get money or you don't have, or you have money. Don't give up. Believe on your God that your God can do it for you. So thank my people for the support that they give me. God will be with them too. They will not fall sick. And I thank this cancer center for the concern of people that come here. We are spending money and we see what we are spending money for. So they are trying. May God help them. Thank you.
Thank you for making it down. I mean, brachytherapy is not something amazing as it happens to develop for patients. Everything about it is like, we are really sort of, so we do things to it, and I'm just telling you, government, really keep your word from family, and again, your things and paper, the patient of the world, it's going to be a fun time in getting. And also useful time to you. By the time you're done, I'm sure you're just thinking so grateful that you're here. So we're going to go straight to the first item. I believe we all have the activity of activity. And following that different of another word, we're just going to go on to welcome myself by the Dr. Echo, who is the better director of NSIA-LUTH. if you go to the Korean, opportunity to have something in several places. And then, you know, she doesn't know that stuff. So it's your message, very, very well welcome.
Good morning, everyone, and welcome again for the peaceful days. For others, was series. So thank you very much for being here. I'm honored to welcome you all to the second NSIA-LUTH Cancer Centre Brachytherapy Summit. This conference to see so many dedicated professionals gathered for us today. We are making a commitment to improving the access to brachytherapy service, which is so key for improving the quality of care that our patients receive. Building up on our first summit, which happened last year, we had an inaugural brachytherapy summit with the theme innovative approaches to improving brachytherapy practice in Nigeria. And that summit centered on the springboard for collaboration and knowledge sharing. We explored advancements in brachytherapy techniques, discussed the unique challenges faced in Nigeria, and most importantly, we began building a strong community of practice. Now, this year, we focus on enhancing access to brachytherapy services in NLMICs, overcoming the barriers. We discussing financial toxicity in cancer care. So we dive into a critical barrier for patients, and addressing this issue, we can ensure that these life-saving treatments become a reality for more patients across the country and even beyond. Today, we are fortunate to have 10 exceptional speakers to share their expertise on various critical aspects of brachytherapy, and the insights will be invaluable in identifying solutions and formulating the roadmap for improved access. We all know that collaboration is key. No one person can do it all. So through the exchange of ideas and experiences today, we can bridge the gap and make brachytherapy a more readily available treatment option. What are the challenges as we begin to look ahead? We know that financial toxicity, infrastructural limitations, and even itself remain significant hurdles. However, by working together and engaging in forums like this one, we can leverage the combined knowledge and resources to accomplish successfully. In conclusion, the future of brachytherapy in Nigeria and the future of LMICs is bright because of all these care. And we have to work to create that future. With very dedication and collaboration, we can ensure that more patients have access to effective cancer treatment. Thank you very much.
What did I tell you about our brilliance, and then you know, attention. And you know, window dressing, it's so transforming from deep down. Thank you so very much, Andrew. Who is the center director, Dr. Toxicity. I heard everything we needed to know about why we're here today. And if you look at the last speaking at the school, the improvements, and the highlight the roadmap to making our really available. And the teaching of practice is actually bright if you create it with ongoing dedication. So, we're here to make things work. We're here to understand how to improve after and that's what we're going to be going to street. Now we have a lot of businesses. We have a lot of celebrating very profitable and we have some international speakers who are going to be representing us actually from outside the country. They do know how agricultural they can be. They also know some of them will have to wake up in the middle of the night so that they can have a conversation with us. So we're going to be taking it one step at a time, very briskly and very impactfully. And right now, the chairman of the official who the Commissioner for Health for Legal State, Professor Akiri, and then the here to be giving most of the opening remarks as well. So the key lecture, which is here today, he has who is very, 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 very capable, and that's Dr.
Greetings from the Mineral Commissioner for Health, Professor National Economy, who would have loved to be here. But today also happens to be May Day. Each of us, the government, is the very supportive year with delegate our workers and my justice. And we'll be asking from here to join them as an early speaker. This is the team for the wonderful taking an opportunity to speak here with regards to the topic of the day. We're working with the invitation and the opportunity to highlight the role of healthcare and nursing and provision of access to professional healthcare services, in which brachytherapy is one of it. Let's talk about what are the experts are going to talk about what brachytherapy is. For us in government, it is a well-known solution in terms of treatment of cancer care. And we know that one of the well-known facts of healthcare provision is funding. Those are cited as NLICs, as they call it. As well, the topic of experts audience. Because infrastructure is one of the things that we have today. We need to have the ability of trained personnel. I think it's not one of those solutions. We need limited access to care. And what are the impacts of limited access to care? It contributes to disparities in health outcomes. The patients having delays in receiving potentially life-saving treatment, such as brachytherapy. And now results to having maybe more invasive treatments and more less effective treatments. And that also leads to poorer quality of life and certainly poorer outcomes. We have to access brachytherapy, particularly the LMICs. For us in the Lagos State, it's a little bit of is very keen on health as your agenda. This is what I think is the thing for the gender health is computer. But the people in terms of social protection, which is in terms that people have equity and access, which some services of which is the whole. The national level, I'm trying to be subsidized through collaboration with and from the people company where the error is. There's 20% of the construction cost. And every time it is 30%, and also the pharmaceutical pays 50%, which means that the pocket for the patients because is not as which in other words, they're giving that to the spiritual people and address that. Leveraging on that, the Lagos State on its own is also committed to developing a sustainable healthcare financing system through the Lagos State Health Scheme, in particular, which is a social health insurance scheme. Now, I think that is probably addressing what we call the financial toxicity messaging. If you diagnose people that have cancer, then they do not have the funds to be able to access care. Then it is a lifetime utility and what people die of. The majority of people, cancer care, the majority of people, cancer care is really popular. Maybe poverty rates and things like that. And the incidence, the incidence of cancers in the community. Most people do this about our experience on the hospital scheme and in terms of being particular, what we can do so far. So the hospital scheme was established by law in 2015. And it became operational after a lot of planning and stops and starts in 2020. And we witnessed a remarkable growth with enrollment of about 114,802 Lagos State residents as at the 30th of April, which is yesterday. This population of residents have continued to benefit from access to essential healthcare services, efficient policy, and the benefits of financial protection. Success stories of the ecosystem health plan is the benefit of cancer care coverage. This, of course, includes brachytherapy. We have a monthly limit of 1.5 million on our standard plan. which covers all aspects of care. We have 2.5 million on what we call our standard plus plan. You will see as well, we also have the provision of up to 2.5 million. Which we can to celebrate what us today. We have a provision of up to 5 million for the public service. We have since the president and we are currently planning music. I believe that so we can perform and qualify as a big part of the smoke. We have to do some time provided all residents in the hospitals. We also people in the aspects provide two types of care benefits we're using that after. The type of that we call studies, hospitals, the original, the former, and the absolute positive outcomes. Until then, we focus on the former and original blastoma. And also we saw common leukemias and necroblastoma for as well. And that's the most prioritizing prevention. So right now, seriously, there's no point. Maybe in LMICs is late detection. People present at advanced stages, and there's really, so much you can do for people. That's so. You only have to attend to sleep because you have to ensure that people have quality of life. I'm going to have something in place to attend screening. So currently we have that on the senior plan, which most people have known. We can and you have the color station is for and mentioned before. Now we have the Halloween standardized translation that we include that in common plans, which people have considered from the language book and then have access to our experience, we are able to detect the values, and then also commenting in terms of the funding able to access and coverage for cause or penetration of the visual to people about the stimulus study. We hope that in the next future, we will be able to see people being more conscious of the needs to ensure their wellness. Really being in the sector. That's why we actually have these focus in the markets and also issues of health. We have to be in the informal sector so that we pull them into insurance coverage. And as we know, private health insurance and people within the private sector, health insurance is a no-brainer because we have the informal sector, which is about 70% of our population. And this is something that is rising. Someone today when somebody asks me to reduce the global governments so we also have some partnerships at the level of the ministry. So the government partners to have programs to support cancer screening and treatment and also to popularize chemotherapy drugs. The industry is currently conversating with some of the companies to see how we can work on placing the drugs to that as well as we can expand for the people concerned that's there. In terms of since we started the cancer companies within the scheme. In terms of the cancers that we have seen, we have 41% in breast cancer, 21% in cervical cancer. 12% is nasopharyngeal, interestingly. We also have 12% as lymphomas, also interestingly. I think the lowest in the one ovarian cancer in the United States. But those are the components that are prostate, apologies. Prostate is between 12% of that, the population of people that have common cancer. and have access to care. In conclusion, stakeholder engagement is really important. We are different areas of toxicity in cancer care. We continue to advocate for policy reforms. We will continue to expand health insurance as the health insurance population grows. We will extend the span of coverage in terms of increasing the amounts that we are using to cover our patients. We will establish patient assistance programs and continue to foster the NSIA-LUTH and stakeholders can significantly reduce financial toxicity and improve access to quality treatment for all residents. I think this is successful relations. Taking a video of someone like that, someone of this sort, you are actually really have a lot to do. The message like a communicate or something that will come up at the end of the day. Yes. Thank you very much for your attention.
Thank you so much, Lana. A round of applause for the PS and CEO of Lagos State Health Management. I was just corrected. I think I said GM before. It's no wonder that he's holding such a lot of people in this and the community was let us just wanting more from you. I was so grateful for this insight, and I think the Lagos State government deserve another round of applause. For the good work that they are doing, I mean, it's a long way to go, but that's a really good start. And the question of everybody is to bridge the gap and make access to cancer care available to Lagos State and populations is quite complicated. Thank you so much for letting us into the conference. And I think one of the times we do have presentation like we would love to make the governor.
So let's present this to you. As an appreciation for the good work that the Lagos State government is doing in improving the quality of cancer care for the citizens of Lagos and opportunity to use for that. Thank you so much.
Please be reminded to the QR code on your table, which you can usually have to get the agenda of the program. So please be ahead and put out, look at some photos that you have already carefully silenced and put of our good housekeeping. And then please you can scan the QR code so that you can have the agenda as a fingertips. We would like to give a little to the great people that are recognizing here. People that you recognize. I would like to recognize our pioneering director. Of the National Institute of Cancer Research and Training, one of my very own Professor Ali Malabi. Go right on there. There's people in the program that say, the next maybe start running one will warm up for of the United States. Together for
we have this brachytherapy platform, but we're hoping that we can sustain every month. The idea is for us to get better and harmonize our brachytherapy in Nigeria. We also want the other centers to please participate in the brachytherapy platform and present your patients so that we can all see the new patients that we get better, so that we can use what we have in our various centers to maximize the patient health. So please, let's do some science of brachytherapy a little bit. Let me crave your indulgence. Move on to menti.com, please. Menti.com. MENTI.com.
Sure. I'll fix them. I'm sharing your screen.
There's a Wi-Fi. Just click on Marriott Conference and the password is here. It's pasted.
Okay.
Sorry for the
Let me show you. Because it's not sharing. That's still with that. And I need to share the second screen here. So people want to cancel them. So that's about why I do it. Yeah. So what you're focusing on is like the screen there. That's it.
Wait, you can ask me to start it from the I think I need to click or something. I think
Once it's here, right?
click on really I'm scrolling. Remove this flyer. Who knows?
Right.
Somebody question. So what do we do? What do we do? What do we do?
Yeah, it's a little bit.
Somebody anybody manipulated this. Hmm. Some people were manipulating the prison.
Somebody's in.
Joshua, maybe it's like yeah. This one. I think we should leave the survey about spoken to you. The survey to show you that the IC don't have the okay, that yeah, it's like
We're going to address where sorry, technical issues are a part of the game. So pressure. If you have a conference without one or two, no matter how many I know, then you're probably not in Nigeria. So people should have together for Nigeria. And in the option there can be four problems automatically. So please don't give us 1 more minute while we wait. And don't forget to scan the QR code on your table so you can see the agenda even as we adjust it. Thank you for your patience. Thank you for your kindness.
All right, so let's quickly run through our chat round today. We are so sorry for the temporary IT glitch. So we'll look at the we'll be looking at this patient. She's Mrs. OE. We'll do it afterwards. Mrs. O is a 54-year-old postmenopausal trader who is para 6 + 2, 6 alive. She's newly diagnosed hypertensive with poor blood pressure control. There's no prior history of HPV vaccination, no history of multiple sexual partners. She's RVD negative and she was referred to us from a peripheral hospital. When she presented to this facility about 1 month ago, she had abnormal vaginal bleeding of 3 months prior to presentation. She had also initially presented to another facility because she came to us in October 2023, where a pelvic ultrasound scan was done for her that showed she had normal uterus with thickened cervix, measuring about 3 by 2.9 centimeters with hyperechoic. Also did a pap smear that showed that there were abnormal epithelial cells consistent with malignancy. She also had a cervical and endometrial incisional biopsy done for her in the same October 2023. The histology reports came back as poorly differentiated adenocarcinoma. So in NSIA, we did a vaginal examination for her that revealed that there was a friable mass occupying the lower 2/3 of the vagina with associated contact bleeding. Chest CT scan that was done for her showed there was no evidence of metastasis. However, her abdominopelvic MRI, which she did in November last year, showed there was a heterogeneously enhancing cervical mass that was measuring about 2.4 centimeters, extending cauda to the upper 2/3 of the vagina and cephalad to the lower uterine myometrium. There was no invasion of the bladder or rectum. There was no extension into the parametrium. There was no encasement of the distal ureters. She had common iliac adenopathy that measured, the right measured about 1 by 1.5 centimeters, and the left measured about 1.4 by 1.6 centimeters. And they showed evidence of diffusion restriction on DWI sequence. So we put her at a stage 3 CI because of the pelvic nodes. And our plan for her was to have chemoradiation done with weekly cisplatin, 40 milligrams per meter squared, to the cervix at a dose of 45 gray in 25 fractions. And then we said we'd give her a nodal boost up to 60 gray for the common iliac nodes that were involved. So she was then simulated and she had a chemoradiation done between 19th of March, and she completed that on 19th of March. Sorry, on the 29th of April. So her post-EBRT abdominopelvic MRI that was done showed that there was complete regression of the cervical mass in the anterior lip of the cervix. Also, it showed that the internal and common iliac nodes that were previously there had also completely regressed. So we made an assessment of good response to treatment, and we planned her for intracavitary cervical brachytherapy with tandem and ovoid. Her hematologic indices were okay, so we went ahead to do a brachytherapy for her, which we commenced yesterday. And yesterday was a day after her EBRT treatment, which is the ideal time to start brachytherapy. You should start a brachytherapy at least after the 24th or 25th fraction of EBRT. You should begin to plan the patient for brachytherapy. So the dose we're giving her, we plan to give her is 8 gray in 3 fractions. So this is her first fraction we're about to review. And during the insertion, her intrauterine length was 5 cm. The tandem, we used 30 degrees. Dr. Vitalis did the insertion yesterday. The ovoids, we used 2.5 centimeters. And we also gave her prophylactic antibiotics and analgesics. So we want to quickly review her image, her brachytherapy simulation slide so that we can see how it was contoured. Yeah.
Please share the whole screen. Yeah, that's what I'm
Patient. Okay, so let me just run through quickly to our EBRT slides. I don't know if it's to be clear enough, just so that we can appreciate the common iliac nodes. Okay. For time constraint, let's go straight to the brachytherapy slides. So we can see that the insertion was done properly. And we'll start with the target, which is the HR-CTV and the intermediate risk CTV. We can see that the tandem was well placed in the uterine cavity. And a 3 cm was measured from the stopper to, we established yesterday that the length of the cervix was 3 centimeters. So we will measure 3 centimeters from the stopper upwards to control for your HR-CTV. And then we'll put a margin around that for your intermediate risk CTV. And the goal of D90 to HR-CTV, we want to get at least more than 87 grades. That's part of the essence of why we're doing 3D brachytherapy. So we can see that the organs at risk were all contoured as well. The bowel bag, like we said yesterday, we don't need to contour the whole of the bowel bag. 2 centimeters above the tandem is sufficient, as the brachytherapy dose will not get there. We can see that the bladder was also well contoured, as well as the rectum, though this rectum was a bit full. And then the sigmoid was also contoured. So I don't know if you have any questions, or do we have any clarifications we want to learn from the whole case of brachytherapy as a whole, especially for those that were here for the hands-on training yesterday. Do we have any questions? If we don't, I'd like to invite the physicists to quickly tell us the doses that we got to the HR-CTV and to the organs at risk. Please, let's put a hand of applause for Nurse.
Sorry. Okay. Good morning, everybody. So for this particular patient, after the treatment plan of the first dose, we have an EQD2 sheet that we use to compile our doses. From the EQD2 sheet, we have an estimate of about 94 grades to the HR-CTV. And this is so because from yesterday's plan, which is our first fraction, we capped it at 10 grade, giving room for possible issues in the second and third fraction. In case we have issues with maybe bowel prep, we have like enough room to accommodate those that would make us fall between the range we want to achieve, which is 80 to 85 grade for the HR-CTV. And for the intermediate CTV intermediate, we have an estimate of 72.2 grade to the HR intermediate. And for the organs at risk, the bladder, we hope to cap the dose at 62.9 grade, which is far below the tolerance of 85 grade for EBRT plus brachy dose. And for the rectum is 59.1, which is also below the tolerance of, which is within tolerance, sorry, of 75 grade. And the sigmoid dose is 64.1 grade, also within the 75 grade tolerance. The bowel is 66.8 grade, also within the 75 grade tolerance to the bowel. Thank you very much. Any questions, please?
So for this patient, we didn't do an extended field because the size of the growth was really small. So we just made sure we covered the common iliac nodes. We just did a mild extension just above where the common iliac node starts. And then went ahead to give up to 60 grades. But you also have to balance the side effects that you're exposing patients. So you want the gross nodes to really be bigger than that to justify why you need to extend the field higher to the paraiotic nodes. So we didn't for this particular patient.
All right, thank you so much. Please put your hands together. That was a brilliant presentation that helped us to see the complexity of planning brachytherapy, like you said. Usually we say brachytherapy, but we connected to the brachytherapy. That's the phonetics of this. So we're moving on. We have an online presentation, I believe, and our collective speaker from another mother nation. She's in the United States of America. Everybody loves them. We've just been waiting patiently online to give us talk on the brachytherapy delivery in LMICs. Dr. Oviye Balogun, this is a brief bio on her because of time. The geography more expensive than what I'm going to say now. But she's an assistant professor of radiation oncology and molecular medicine, specializing in treating gynecological and breast cancer. She graduated from Harvard College, Yale University School of Medicine, and New York University. Her research and advocacy focus on eliminating domestic and global cancer disparities in gynecological and breast cancer, which the population facilitator from today. Are you ready with your presentation from Assistant Professor Oye Balogun from Yale plus, well, Cornell plus, the list is endless, yes. I'm going to get up on our list today.
Yeah, sure.
I know from Nigeria. Yes, our assistant professor. So good to see you.
It's wonderful to see you all. I hope that you can hear me.
Okay, yes. I'm yet to hear you. I can't hear you yet.
She's speaking out.
Can you hear me now?
We can hear us.
Hello.
Can you hear me now?
Yeah.
Oh.
We always reach out, so she's not always there for us. I mean, I can't remember how many times she has just made herself available to advance the cause of cancer care in Nigeria. In another show, we're working on the meeting. Can you hear me?
Yes, I can hear you.
I hear you now too. Thank you so much. I'm excited and waiting on you.
Let me see what I can do. Maybe if I join by...
No, we can hear you.
Oh, you can hear me now? Wonderful. Thank you so much. Odabo, everyone. Good morning. You can hear me? Okay, I'm just going to start speaking.
We can't hear them. We need to hear you. Please from here, so.
enter your meeting ID, followed by pound.
Yeah. She's not the one speaking just now. She's the one speaking this on here.
Can you hear me now?
Answer this for so now. Just stop now.
Can you talk? Can you hear me now?
Very well.
Yes or no?
Yes, we can hear you.
Perfect. So I'm going to start speaking now, and please, in the chat, let me know if you do not hear me, so that I can stop. But I want to share my screen. Please also confirm that you can see what's on my screen.
Yes, we see your screen.
Wonderful. So everyone, good morning. Thank you so much for the opportunity to speak today about standardizing brachytherapy delivery in low and middle income countries. I consider NLCC to be my second home, if not my first, since I am Nigerian. And I just congratulate all of the organizers. I congratulate all of the organizers of the summit on really this magnificent efforts to improve the delivery of brachytherapy in Nigeria, and I dare say beyond. So what I want to do first is to lay the groundwork about what we are up against. What is the state of cancer, and specifically cervical cancer? And then what are some of the strategies that we can use to improve the delivery of brachytherapy? So we know that, unfortunately, cancer is on the rise worldwide. We know that by 2035, there may be as many as 24 million cases in 1 year. Unfortunately, low and middle income countries are disproportionately burdened by cancer, representing 57% of cases and 65% of deaths. And I'll let you know that when it comes to cervical cancer, low and middle income countries represent 90% of deaths, and that should not be so. So in order for us to properly tackle the issue of cancer care in low and middle income countries, it's important that we strengthen all the pillars of cancer care. And I sometimes, tell my colleagues that radiation therapy is the underappreciated modality of cancer care, because many people frequently just think about surgery or they think about chemotherapy, but this day and age, we know that since 1896, we've had radiation therapy, and it works excellently. In fact, we know that about 50% of cancer patients are going to need radiation therapy at some point in their treatment, whether for definitive care or palliation. So it's important that we make sure it's strengthened, and that's why the work that was done to establish NLCC is so important. When it comes to cervical cancer, this cancer, unfortunately, is still a disproportionate burden in our setting. When you look at high-income countries representing the upper diagram, you can see that cervical cancer is not even among the top 10 cancers that are diagnosed. It is, within the bottom 10, the latter half. It's about the 7th or 8th highest cause of deaths when you're looking at high-income countries. But unfortunately, when looking at low and middle income countries, cervical cancer is still, in some nations, the number 1 or 2 cancer, and also the number 1 or 2 cancer, and also the number 1 or 2 leading cause of cancer deaths. And we know that there's a disproportionate burden in certain parts of the world, including sub-Saharan Africa, the Caribbean, and parts of Asia and Europe. So Rightfully so, the World Health Organization put out this call saying that we need to accelerate the elimination of cervical cancer. And they laid out 3 points that they believe will get us to the goal of elimination. I'm sure many of you have heard this 90, 70, 90, meaning that 90% of individuals, specifically young girls, should be vaccinated with the HPV vaccine by 15 years of age. 70% of women should be screened with a high performance test, and that's the HPV test or the PAP test by the age of 45. And also 90% of women who have cervical disease should receive treatment. And what I want to do today is to focus on the treatment aspect. So when thinking about this issue, this is how I like to frame what I believe will get us to 90% of cervical cancer patients receiving treatment. And specifically for the purposes of this presentation, I'm talking about standardizing across the board so that we get to 90% of individuals being treated with brachytherapy. And I think about the 3 A's: availability, affordability, and andragogy. And what that means, andragogy is just a fancy way of saying adult education. I think many of us have heard about CME, continuing medical education. So I think that those principles will help us get to that goal of standardizing the delivery of brachytherapy to nearly all women who are who are diagnosed with cervical cancer and need brachytherapy. So I will focus primarily on availability, and then I'll touch briefly on affordability, which is the theme of this conference, financial toxicity, and then andragogy. So when it comes to availability, we know that we have an issue. Brachytherapy is not as widely available as it should be. In this study that was published in 2020 by the IAEA, they showed that in their database, you have over 7,000 radiation therapy centers, and you have about 14,000 teletherapy units, but only 3,000 brachytherapy installations were performed. And they know that only 3% of these installations are happening in Africa. So you remember the map that I showed you, how sub-Saharan Africa is disproportionately burdened by cervical cancer, yet we only have 3% installations of brachytherapy units in sub-Saharan Africa. To further drive home this point, there was an update that was published by my good friend, Dr. Elmore. And what they showed again is about 52%, over half of the 54 African countries have access to external beam, but only 39% of countries have brachytherapy capacity. And no country had capacity that met their needs. In fact, when we look at 2012 to 2020, we see that the number of cervical cancer patients per year increased by 48%. Nearly 50%. But when it comes to how many brachytherapy units were installed to try and meet that need, there was only a 6% increase. So clearly we have limited resources. And that's why, again, what you did at NLCC to reinstate your brachytherapy program is so important. And we have to always make sure that when we do have access to that brachytherapy, that it's used optimally. And so when I think about how to make brachytherapy, when it's available, how to use it optimally, one of the things we are thinking about is the technique, 2-dimensional versus 3-dimensional image-guided brachytherapy. And you can see clearly here, we used to use X-ray-based planning, as you see on the left. And clearly, that is inferior to, on the right, CT-based planning. What you see here is that the X-ray-based plan, you can't even see the normal organs. You can't see the bladder, you can't see the rectum. As Dr. Njoku eloquently pointed out in just the previous presentation, we want to be able to see those organs and quantify what dose is going to those organs so that we can minimize the risk of severe side effects like proctitis or cystitis, or even things like perforation in those organs. And of course, we want to make sure that we can see that soft tissue so that we can best target the cervix, which is our main goal with brachytherapy. And there have been some papers that have talked about the benefit of three-dimensional image-guided brachytherapy. And just in summary, this paper that was published in 2009 showed that when you had three-dimensional plans, you thought you were giving, with the two-dimensional plans, people thought that they were giving 7 gray with each fraction, 7 gray times 4, one of the accepted regimens, in addition to 6 gray times 5 or 8 gray times 3, as was mentioned in the previous case. But when it comes to the actual dose that you are giving, it was actually 4 gray. Right? Especially for larger tumors. So if you can't see those sorts of things and try and quantify the dose that you're giving properly, it's going to be very hard to optimize the usage of brachytherapy. So it's really important that we make three-dimensional image-guided brachytherapy available widely, because that's what's going to make the difference in us being able to control cervical cancer properly. Also, one of the points that was made was that, the dose to the bladder, like I mentioned, when you're using the X-ray based imaging, they would usually use what we call ICRU points, the ICRU bladder point. But that point was actually, not accurate. It was not giving you the proper readout of how high the dose was, because the dose was actually higher that was going to the bladder than was appreciated on the two-dimensional plan. So for both of those reasons, for the fact that you have to make sure that you're giving the right dose to your cervix, it impacts local control and overall survival, and you have to make sure of the dose that's going to your normal organs. That's why we really need to invest in three-dimensional image-guided brachytherapy. So there's been some talk, individuals in the world of brachytherapy will know that a number of individuals propose, MR-guided brachytherapy as the standard of care. This has been shown in studies like Embrace that MRI is excellent. As you can see from these images, it's really excellent at showing the soft tissues and helping us discriminate what's tumor versus what's normal, and also picking up things like parametrial invasion. However, even though this is touted as the gold standard, 70% of the world does not have ready MRI access. So we have to be cognizant of these differences in ability to provide MRI-guided brachytherapy. And so this is an issue that really hits home for me because we need a solution. We can't say this is the gold standard and more than 50% of the world cannot meet it. So in thinking about this, I've started thinking about ultrasound-guided brachytherapy. And what we know is that we're already bringing ultrasound into the brachytherapy procedure. Usually we're using it to make sure that we are not perforating while we're placing the tandem and ovoids, or the tandem and ring. But what we need to do is take it from just a means of us saying we haven't perforated, the tandem is still within the uterus, to using that modality to also design plans. So not just confirmation of applicator placement. I believe that we can make this ultrasound a means for us to deliver 3D guided brachytherapy. So when you look at the diagram over here, what you see is that this is the brachytherapy applicator, the ovoids and the tandem. And people can use either transabdominal ultrasound or transrectal ultrasound. of late, there's also been this development of newer ultrasound applicators that are called extended transrectal ultrasounds. And what they do is they reach further into the rectum and are able to show better the entirety of the uterus, as well as the normal organs that we care about sparing. And this is important, especially in settings where we're still seeing a lot of locally advanced disease. And if you're having intrauterine extension at the time that the patient presents, it's so important that you also make sure that the entire uterus is getting at least 60 gray at the time that you're delivering brachytherapy. And people feel that extended transrectal ultrasound may help to give that visualization so you really are able to confirm that you're giving dose appropriately. So there have been a number of individuals who have been using ultrasound as a means of image-guided brachytherapy. So some of my colleagues at the Peter MacCallum Center in Australia, if you look at the diagram on the left, you see the ultrasound image. And if you look on the right, what you're seeing there is the MRI image. And it basically looks like mirror images of each other. You know, there are differences in, the grayscale, but I believe that you can make out the things that you need to see. You can make out the uterus and the cervix especially. You can make out the bladder. And what they did here was that they took measurements systematically from the os of the cervix all the way to the tip of the tandem applicator. And they wanted to see, are these measurements going to be different between ultrasound and MRI? And ultimately, their studies, in addition to many others from Thailand, even the members of the Embrace group have done studies showing that ultrasound measurements are equivalent, within an acceptable range, less than 3 millimeter differences in the measurements that you get from ultrasound versus those for MRI. In addition, they've gone on to do some studies where they used ultrasound to design the brachytherapy plan. And what they've shown with those studies is that you get just as good outcomes. They followed these patients. In Australia, they followed these patients for at least 3 years and showed that there was no decrement in local control. So to me, ultrasound is really the way forward for low and middle income countries to be able to standardize the brachytherapy delivery and deliver this image-guided brachytherapy that's become the pinnacle of what we can give our patients. So this is a schematic for a trial that I'm working on in order to look at an alternative brachytherapy workflow. So as you can see, patients will be put under anesthesia. The brachytherapy applicator will be positioned under ultrasound guidance. And then once everything is in place, including your packing, we're going to get ultrasound images of this the device in place and of the cervix, the uterus, and the normal organs. Then what we're going to do is have patients go for recovery. At the same time, we will start contouring using those ultrasound images, and then we'll be able to generate a plan. And I think presumably we'll have a plan by the time the patient is ready to then move on with their treatment. So we're going to have people, go ahead, get MRI, get the CT SIM, and we're going to also make an MRI-based plan. But we want to see this ultrasound-based brachytherapy plan. Are there any differences, significant differences between the size of the cervix that we contoured, between the doses that we are seeing or measuring for the bladder, the rectum, the sigmoid, or the cervix itself compared to the MRI-based plan? And I think, there's some clear potential benefits here. We think that you're going to decrease the time that it takes, even if you don't do MRI, by doing the ultrasound right away before the patient has to go to the CT. You're going to make that workflow push ahead, push faster. You're going to decrease the time under anesthesia for those centers that keep people under while they're doing the CT simulation and designing the plan. You're also going to, if you eliminate that CT ultimately, you're going to be able to decrease time under anesthesia, which we know can have side effects. And also you're going to decrease movement of the patient from, you know, they were in your procedure room, now they're being taken to the CT, now they're being taken to MRI. You're going to decrease the jostling of the patient, which causes pain and potentially displacement of your applicator. So there are so many potential benefits that I see here for low and middle income settings. I also want to touch on the fact that I believe this is going to impact positively treatment duration. As Dr. Njoku mentioned in her presentation, they really delivered the standard of care with that treatment. They started 1 to 2 days after she finished her external beam. And the reason it's so important is that we know that if you give the whole course of treatment from start of external beam and concurrent chemo to the end of brachytherapy, if you make that less than 8 weeks, that has significant impact on how, on overall survival. And that's shown in multiple studies, including this one, where I show that people who had brachytherapy clearly are going to live longer than those who don't. And then also on this side, under the diagram B, if you had radiation therapy that took more than 8 weeks in the blue line, you had worse survival than if it took less than 8 weeks. And then this is also just showing that, you know, if your hands are tied and you have to give brachytherapy later, let's say someone couldn't afford it and they finish external beam and then they come to you and they say, now I have the money for brachy. It's good that you gave them something at all rather than nothing. That's what this paper is saying. But I think that by moving to ultrasound-based treatment, hopefully, you know, those imaging studies, like sometimes we want them to get MRI and people can't afford that MRI, even though it helps guide our treatment. Sometimes the additional CT, people can't afford that. So maybe this is a way for us to get more affordable care. And I'll let the experts talk about that in the interest of time in the upcoming sessions. And now I'll briefly touch on, you know, adult education, the importance of it. I think we've talked about chart rounds. Dr. Njoku gave a phenomenal demonstration of that. We know that brachytherapy implant quality matters and that we have to make sure that we are doing all of the things, giving the right dose, protecting the normal organs. And there are a number of different educational initiatives in addition to the peer review that we do in order to make sure that we are standardizing the care and meeting up with the proper dose constraints and the proper target goals that have been delineated for best practices in brachytherapy. So with that, I'm going to, you know, again, just share some of the pictures for where we have engaged in education here at NLCC. Like I said, I consider this place my second home, and I'm just so proud of the way that you are leading the charge to improve brachytherapy in Nigeria and, dare I say, on the continent. Thank you so much.
So thank you so much for your great as always, my prop. And there's a profound statement that she made that I would just like to repeat from one of the studies that she highlighted, and that is that she used this word clearly. People who take brachytherapy will live longer than people who don't. And that just shows you the need for all of our cervical cancer cases and appropriate for them to have brachytherapy, which she has totally done justice to, something that was given to her. And one thing that we know is that affordability made for us to be able to get all of this may be a problem. But the new innovations of having ultrasound guided brachytherapy is exciting because that's something where and it's exciting to note that when they compare this with the gold standard prototype guided brachytherapy, they are seeing that the difference is not so much. And if it's so this is things we need to follow through on, see how we can make this for us here. Do we have any questions? Thank you again. Please put your hands together for the very brilliant Professor Oye Balogun. Thank you. You did so much good justice to that, and we're excited to have listened to you. Do we have any questions that we would like to ask her? So that there are a few things, or would you want to just quickly read questions? She will be sitting up in the middle of the night where she resets, just be here for us. So we're so grateful. Thank you for taking the time. Well, sometimes when people don't have any questions because you did that, please really great job in breaking down entities that you were presenting. And I guess I'm excited.
I believe there's one question online.
Oh, great.
So I can read it. It says it's from Dr. Yubi. And Dr. Yubi is asking for interstitial brachytherapy. Do you perform it with empty bladder with ultrasound? And in your center, do you have an MRI that's close to your CT scanner? So great questions. So with interstitial brachytherapy, or just with brachytherapy in general, I actually we place a Foley catheter. So I actually don't tend to fill the bladder again. There's some individuals who will instill, saline or into the bladder and clamp it during treatment. But I've found that I don't have to do that because the dose to the intestines, people sometimes fill the bladder thinking that it will push the intestines, but for my practice, I haven't found it to be a problem. And then the question regarding, do I have in my center an MRI that's close to the CT scanner? The answer is no. I work in Brooklyn, which is one of the, in New York City, within New York City, there are unfortunate cancer disparities. So while Manhattan has pretty good outcomes in terms of cervical cancer, there's almost a 2 times higher death rate due to cervical cancer in Brooklyn, which is just, some maybe 40 to 60 minutes away. So we do not have in Brooklyn an MRI that's near the CAT scan. And that's one of the things that introduces delays. In addition to the fact that with the MRI, we're at the mercy of the radiology center, the radiology department. If there's an emergency for the radiology department, that slot that was promised to us for imaging the patient is no longer available. And so, that need to transport the patient from the MRI to the CT, those are some of the delays that we're trying to avoid by looking at ultrasound guided brachytherapy. Finally, Dr. Yubi asked, can you see the uterus clearly with an empty bladder? Oh, when I'm placing the device, I fill the bladder. So intraoperatively, I fill the bladder because it's very hard to see the uterus when you're placing the device without the bladder. So what I was referring to earlier is when I'm delivering the radiation, I don't fill the bladder. But when I am placing the device, I need to fill the bladder so that I can see things clearly.
Thank you so much. Do we have any other questions? Did I see your hand up, Rachel? All right, so please put your hands together for Oye Balogun. Yeah, thank you, and it's really grateful to you for taking the time. Thank you. All right, so I would like to quickly go on the conference of Professor Arnold. Please forgive me if I'm not saying that right. Arnold. The leading oncologist at the Lagos University teaching hospital. Thank you so much. I can see your hand just so that. No, I can thank you, Mama. Because I'm with me as the guiding oncologist, as is also the immediate president of DLC. Powerful, powerful president in the. Thank you for coming in, Ma. Professor, the global. Are you with us? The ophthalmology with the really fine glasses. Very appropriate. Thank you. I'll come and see you later, man, because sorry, your teeth there with something that really makes me. So we're going on straight out the tea break. The tea break. You will notice the quick rearrangement going on here. So please do not be alarmed. Your things are safe, I believe. And then we'll just quickly take our tea break and come back and sit down. Because we still have an international facilitator sitting up in the middle of the night where they are, so that we can start at 11:20. But ladies and gentlemen, tea break time. Thank you so much. I just walked to the back of the hall. And the hall that they expanded a little bit just to make a bit of room for moving and all of that. All right. Thank you.
Go ahead. Yeah, stop the video. Put it up. So let's get that back. Again, some people don't like it.
I don't know if you can see the screen. Let's go to menti.com and type in that code.
What's the code, guys?
Please report on the screen 59101374. Menti.com. menti.com. 59101374. Victor Echo. We're about to start the next session, please. So when you type in the code, just answer the question. What is the primary goal of brachytherapy in treating cervical cancer? That's correct.
So that's what the spelling.
Menti.com, menti.com. Then you type in the code 59101374. Somebody has answered. Just refresh. What is the primary goal of brachytherapy in treating cervical cancer? Just 3 responses, but up to 80 here. Please answer. Online, I don't know if you can hear us.
I'll put the link for everyone.
Just mention it. What is the primary goal of brachytherapy in treating cervical cancer? Is it 59101374? That's the code. The code is on the screen. 59101374. The answer. We want to eradicate cancer cells. The primary goal is to improve overall survival. So let's quickly to start the next session, please. Brachytherapy is commonly used for treating cervical cancer. Quickly. Commonly. I'm supposed to be saying interstitial. So yes, intracavitary is the commonest. There is also interstitial if you have the interstitial needles. Brachytherapy can be used as a standalone treatment for early stage cervical cancer. True or false? Okay, so most of us are on the same page. What are the potential complications associated with cervical brachytherapy? Infection, bleeding, vaginal stenosis, all of the above. What type of imaging is used to control GTV for brachytherapy? All of the above is the answer. Everybody got it. So it is only MRI that we can use to control GTV for brachytherapy. And we say CTV high risk because we use CT that we can actually use to control GTV for brachytherapy. What is the average height of the normal cervix that could be controlled for HRCTV? We had it yesterday during the hands-on, so this should be easy. Perfect. So it's 3 p.m. Organ constraints except. What are the organ constraints for cervical brachytherapy except? So sigmoid colon is an organ constraint. Rectum is. What is not is the intermediate risk CTV. What do you do for bone preparation before brachytherapy? Please answer quickly. Our next presenter is online. Exactly, to minimize radiation dose direction. And this is the last question, very important for today. I don't have 12. Go. Today, my own question. Black market. Which I don't have 12.
For just answering all of these questions today, thank you so much. So welcome back. I hope you had okay. So right now we're going on to our next presentation. Our brilliant facilitator is standing by already. We're going to take the presentation by Fumiko Chino, Dr. Fumiko Chino, who is talking to us about financial contributing in cancer care. And that's our keynote speech for the day. Dr. Fumiko Chino, MD, is a cancer researcher, physically attending in radiation oncology, the lead of the affordability working group at Memorial Sloan Kettering Cancer Centre. She is the director at the Cost of Care Group, with EPO working to improve affordability in healthcare, and the recipient of the inaugural 2022 ASCO Excellence in Equity Award, and she's also the chair in some ASCO quality. She's an great manual for her. In the interest of time, I think giving the so we also know that this is an excellent faculty who standing capacity in managing in the particular topic that she has been giving financial toxicity in cancer care, and she's our keynote speaker. So let me quickly invite Dr. Adebo to come and finalize this introduction and then give the floor to Dr. Fumiko.
Good morning, everybody. So I'll just say a bit about Dr. Fumiko. So thank you very much for honoring this invite. I attended a summit like this in New York while I was there on my fellowship. In cancer patients there. So before then, I used to think that financial toxicity of Africa, by Africa, through Africa, all over that. And that was so that discovery financial toxicity. Then, grants and I believe that is actually the picture, not knowing that it's actually the 1% of the 1% that is to make it into specific. So during the meeting, I actually knew that it was actually a across for the perspective of it's actually parties. We have the information and experience over actually relate well. So join me once again. Welcome Dr. Fumiko Chino. Thank you.
Thank you. Can you hear me okay in the room? I'm going to share my slides. Let's see. All right. Can everyone hear and see me okay? I'm hoping that's okay. Well, I'll just start and hopefully everything is going okay. Please let me know if there's not good audio. I'm talking about financial toxicity and cancer care from New Jersey from my clinic. I'm sorry I couldn't be there in person, but I'm very passionate about this topic. I have no financial disclosures about financial toxicity. I try to level set whenever I start speaking about financial toxicity to talk about how common it is and about how there's actually slightly more people who are worried about the financial burden of a cancer diagnosis than from dying of cancer. This is something that's very much rooted in the US and European healthcare systems in terms of describing the problem. So I will admit that most of the data I will show you will be from a US context. But I don't think that it's a surprise to say that many patients and caregivers are having to make some pretty large sacrifices in order to afford their care. What we know is that financial toxicity and affordability is really causing a lot of anxiety for finances. And that specifically being able to afford cancer treatment is a concern, certainly for a significant minority of patients. We know that this is, something that's really gained a foothold in the medical literature. So even our, most banner medical journal notes that the cost of care is a side effect, just like any other. And although we would never start someone on a radiation plan without warning them about, for example, the risk of, scar tissue that could affect their sexual function or the loss of their hair from chemotherapy, we're routinely committing sometimes our patients to month-long treatments with ever not really warning them about the financial implications for them and their families. This is something that even kind of our regular news kind of understands in terms of they know that the costs of care are really causing a lot of people to skip out on their treatments, potentially cut corners, and they've seen these costs, how it affects, their family members, their neighbors, people at their work. It's something that's pretty pervasive. And this is where I'll say, I do have a financial disclosure related to financial toxicity research, and that's that I've paid a lot into it, meaning that I have suffered from financial toxicity myself. So as a cancer widow, I came by this topic quite naturally because when my husband was diagnosed with cancer, we had really insufferable costs related to his care. And then after he died of cancer, those costs really followed me for about a decade. So I had debt collectors calling me. I had a lot of financial problems just related to that big debt that hung over my head. We know that financial toxicity, so what my mentor when I was in training, defined it as Dr. Yusuf Safar is a new name for a growing problem. So the name is new and the problem is growing, but it's not like it didn't exist before. Cancer treatment has never been free for most people. And the financial toxicity is really something that's kind of flourished over the last 10 years, we would say. And financial toxicity is sometimes misused because there are high costs related to cancer care. And it's can be a burden for virtually anyone in any healthcare system. But it has to do with how the costs are actually affected the patient. So it has problems that a patient has related to the cost of their care. So again, not kind of the burden of overall medical costs, but the burden on specifically the individual. And as someone who has kind of gone through this myself, what I said is that, these high costs are really leaving a lot of families adrift in debt. And these out-of-pocket costs cause real quality of life and quality of care problems. Keeping in mind that a lot of the research in financial toxicity have been done with people with health insurance. And so, obviously the burdens on people without health insurance are even that much higher. What we know, at least from the US context, is that we're talking about billions of dollars. And we're talking about costs that can potentially be durable over time. And so the out-of-pocket costs, meaning what you have to take out of your wallet to pay for your treatment, and also the time costs, meaning the opportunity costs of not being able to work, having to retire early, having caregivers who can't work. These are really something that can endure over time, and that even, for example, 10 years after a cancer diagnosis, there are both out-of-pocket costs and also time costs. So financial toxicity can really linger. And again, in the United States, at least, it's $20 billion every single year. That's the patient economic burden. We know that there are specific measurable effects from financial toxicity. We know it decreases quality of life for our patients. We know it decreases their satisfaction with their care, and we know it actually erodes the quality of care that they receive. There's a lot of research showing how people with high financial burdens have lower quality of life. There's a lot of intersectionality here, meaning that sometimes it's actually quite challenging to say what is driving the low quality of life. Is it the financial distress? Is it the quality of care? Is it the fact that they have more advanced diseases? They're all very much interrelated. But we know that people who have high financial burdens have higher anxiety, they have higher fatigue, they have lower social functioning, and they have lower physical functioning. We know that there's a decreased satisfaction that patients have with their healthcare when they have financial burdens. Again, this is it makes sense, right? But for people who have high financial burden, their scores on this validated satisfaction survey are primarily shifted towards the not satisfied. And some of the specific aspects of their survey responses that decrease are actually trust questions. So sometimes my doctor makes me wonder if their diagnosis is correct, or I have some doubts about the ability of the doctors who treat me. So, having higher financial burdens actually starts eroding these aspects. So not just general satisfaction or, satisfaction with the financial aspects of care, but some real, trust basis for, if patients don't trust us that we're, doing the right thing by them, they will most likely start compromising their care on their own. And that's certainly what we see is that, there's a lot of research showing that patients are just not getting the care that they should get or that they're recommended to get because they can't afford it. Again, this is US-based research showing that about a quarter of patients had some sort of medication non-adherence, meaning that 1 in 5 didn't even fill a prescription related to the cost of it. And 1 in 20 who skipped, took less of, or didn't fill chemotherapy prescriptions. So something that could obviously, directly affect the efficacy of their cancer treatment. We know that certain things are, if quality of life, quality of care is going down, there are certain things that are going up. Personal family burden, risk of bankruptcy, and overall the risk of death goes up when financial toxicity peaks. We know that our patient family members and patients are having to make some large sacrifices. We know that, for example, over half were having to use their savings if they had any savings at all. We know about a quarter had to borrow money or go into debt. These are patients who are on active treatment for cancer. And we know that if you survey patients on cancer over time, they're just going to continue to have mounting burdens. So by the end of 1 year, 3 out of 4 patients in this one analysis had some sort of major financial hardship. So that includes, debt or loans or, having like loss of income, having to do things like refinance their home or sell their home. And that the quality of life was really decreased if they had early financial burdens. From an objective standpoint, we know that actually patients are having to put off major purchases. They're being contacted by debt collectors. They're having to take on credit card debt. They may see their credit score decrease, which maybe affects their long-term capacity for getting a loan. And this survey was specifically actually done in survivors that were a median of 8 years after their diagnosis. And so these things can, again, really linger in our patients and families. Even when you survive cancer, you can actually have these objective financial harms. You can be in collections. You can have, you can have liens on your property. You may even lose your property related to, for example, creditors knocking down your door. We know that there is a risk of bankruptcy, for patients who have a cancer diagnosis. They're more than 2.5 times likely to have to declare bankruptcy in the context of a cancer diagnosis. So people can really just go broke related to their care. And it can, again, drag the whole family unit down. You can have really generational poverty related to a cancer diagnosis. And ultimately, there's a risk of death. So for this study, they found that for people who declared bankruptcy in the context of cancer diagnosis, they were just more likely to die. We know that healthcare disparities can help drive these high burdens of costs. And we know that unfortunately, financial toxicity also can drive gaps in care. And when we think about kind of the capacity for someone to be able to even maintain a good health status, to be able to work, to go to things like have cancer screenings, or to be able to make it to follow-up appointments, there's many times where people are exiting this kind of best path just related to the burdens of life, and that there are many aspects of care that are not equal. And we know that, for example, something like structural racism, and this study was done in the United States, the differential effects of economics for race, ethnicity, and education, it's very expensive. And so as a healthcare system, we actually pay for this inequality by increased burden in certain populations. So that's either actual differential health outcomes that end up being much more expensive. We know that there are different access to care issues for different populations. So for example, our study found that certain populations are more likely to have to skip out on their chemo appointments, have to spread out their chemos, have to, only have one option for what doctor to choose. These things can be disproportionately felt in certain communities. And we know that there's actually a disproportionate financial impact in certain groups as well. This study of about 2,500 women with breast cancer found that Black women actually were more likely to have an adverse financial impact of their cancer diagnosis. They were more likely to have lost income, and they were more likely to face transportation barriers in order to afford their care. Because even honestly, if you can afford your cancer treatment, you may not be able to, get there. When we look at all comers, we know that, at least again in the United States, that Black patients are 5 times more likely to be denied health insurance after a cancer diagnosis, and more than twice as likely to report being harmed financially because of cancer. We know that this is actually leading to the potential risk of homelessness. This study found that 1 in 20 Black or Latinx women with early stage breast cancer actually became housing unstable related to the financial impact of their cancer treatment. Again, so not something that just affects the patients, but also potentially her children. We're talking about the idea that, it's much harder to get someone a cancer treatment if they're living in their car, and that these burdens are disproportionately felt in certain communities. We know that this inequality of access and affordability actually can affect our ability to get people enrolled on clinical trials that actually help advance the science. And so our clinical trials aren't necessarily enrolling populations that are representative of the patients that have that disease, and that there's a lot of financial barriers to enrolling in clinical trials. One of them is just getting to the facility that has the clinical trial open, because there's all these known costs of clinical trial participation, but there's also all of these hidden costs. And that actually over time, we're not just not doing better, we're actually doing worse in terms of, again, within the United States, the representative sample of, for example, Black participants in phase 1 clinical drug trials. We know that everyone had large burdens under the COVID-19 pandemic, and that certainly our patients with cancer and anyone who is high risk had disproportionate burdens. This survey was focused on patients who were young, who were cancer survivors, and found that there was, some significant hardships. People lost their jobs, they didn't have enough money to pay for rent or mortgage. This is not related to their cancer, but actually to COVID. But then you see that reflected in actually some of the corners that are cut related to their actual cancer diagnosis. So things like postponing their preventative healthcare, not seeing a specialist, having a problem but not seeing a provider, that sort of thing. As I said, most of the financial toxicity research has been done primarily in the United States, but I did want to walk through some research that was in a larger kind of global context. We know that for nations that have a publicly funded healthcare, that they unfortunately still have financial toxicities. So that includes both out-of-pocket costs, and maybe more importantly for these countries, actually the lost income, which is still a large issue. There's also some significant travel and accommodation costs because the cancer care is not typically in someone's backyard, and they have to have significant burden to kind of get there. What we know is that these studies found that this affects not just patients, but also their caregivers. In research specifically in low and middle income countries, the analysis has found that patients who live in larger household size are more likely to have higher financial toxicity, people who have more intense treatments, meaning multiple cycles of chemotherapy, and people who are treated in private health facilities. And the aggregate aspect of this research found that it was, US dollars over $2,500 for the cost of treatment, which, as you know, can be, truly unaffordable for some of our patients. We know that there is some, risk of catastrophic burdens. This was a small study, but what it found is that over half of the patients didn't have any form of health insurance at all. And the median cost was about $2,000 for their actual treatment, and that this pushed people into really catastrophic healthcare spending. So this is essentially thinking about eating up the entire amount of free spending for the entire household related to surgery or lost income, etc. We know that this is also something that has affected, for example, patients in Egypt. This is 100 patients with breast cancer in Egypt, showing that patients significantly, a large portion of them needed financial assistance. They had difficulty affording their medications. They lost their jobs after a cancer diagnosis, and they had food and transportation insecurity. So not being able to get good nutritious food or a consistent amount of it, and not being able to actually get to their appointments. I think something to highlight is that, of course, it is not every single person who has these problems, but for those patients who are having barriers to access, it's obviously excruciating. Just, to outline a little bit more of some of the research that's been done. Again, job loss is a common concern. We know that patients are having to get money from their family. So again, not just a burden on their household, but even kind of their extended networks. And that, even just the idea of having health insurance, which in the United States, obviously, most people have health insurance. This is something that is quite variable based on the country where you're, treating people with cancer or being treated. Some research from Rwanda found that, patients were having to sell property. They were actually having to obviously use their network from friends and family and from the public. And again, taking loans, if they have the capacity for taking loans, which again is still not consistent. What we know is that financial toxicity is pretty pervasive, and what I'll highlight is that I work at Memorial Sloan Kettering, which is, World Leading Cancer Center. We have a lot of resources. But here, even at MSK, you know, about a quarter of our patients have some sort of financial toxicity when we actually analyzed people who are on active treatment. So that includes, you know, having you know, a payment plan or being, you know, having to settle, utilizing our financial assistance programs. And what I'll say is that not all cancer types are affected equally by financial toxicity. So again, this is from our data at MSK, and you can see that actually cervical cancer is actually one of the top cancers that patients who kind of walk in the door of the cervical cancer diagnosis have some of the highest risks for financial toxicities. And I just highlighted the gynecological cancers because I think they're really interesting to kind of look across the spread. But certainly cervical cancer is one of the most financially toxic cancers that we see. So I want to talk a little bit about how to move forward from financial toxicity, you know, what we can think of in terms of solutions, because the problem itself can be very distressing and sometimes insurmountable. I do think it's helpful to think about things in like a framework, to think about all of the different ways, all of the different inputs, and all of the different ways that we can potentially intervene. Within the larger context of, you know, it is very hard for someone I see in clinic for me to just like get them health insurance, right? So like I can point them to resources, yada, 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 but like my capacity as an individual, like I can't just give someone health insurance. But things that we can do from the provider side are, you know, trying to screen, trying to provide financial assistance or facilitate assistance, help with patient navigation. These are all, you know, ways of mediating financial toxicity. From the patient side, you know, can we improve, for example, their financial literacy? Can we give them better support? Is there a way of providing some sort of basic income for people with cancer, which is something that's actually been tested, at least here in the United States? What are the different ways that we can measure this? Like, for example, the quality of care, their treatment adherence, their symptom burden, and of course, things like survival. We know that there is really enduring needs that have for people who have a cancer diagnosis that can affect their finances. So things like, for example, the need for ongoing treatment, or the fact that their treatment is actually affecting their ability to work. We know that, for example, having to have a caregiver affects not just the finances of, you know, the family unit, but also affects the health and financial stability of the caregiver. We know that some people just don't have any savings to begin with. And so that was one of my first mistakes I made when I started doing financial toxicity research, is that I just assumed that everyone had some sort of savings. And so when I asked, you know, are you using your savings? It never even occurred to me to have an option that says I have no savings. But of course, as you get into this, you realize that a lot of people don't have any savings at all. Like it's not, there's certainly no guarantees that you would have any money in the bank other than, you know, just the income that you brought in that week. We can really think about these potential solutions for financial toxicity within nesting frameworks, from kind of policy to, you know, provider, institution to patient, because any problem that has many different inputs, there's not one single driving force of financial toxicity. It means that there are many potential solutions, all of which can make care slightly more affordable. None of them will make care $0 to patients, sadly. But at this point, you know, we want to have solutions that are viable and feasible, and also sustainable. We know that price transparency is a lofty goal, because when our care is unexpectedly costly, my own research shows that it's associated with unexpected, higher overwhelming financial distress and increased willingness to pay. So that means that essentially things like surprise bills, or when the cost changes, you know, patients can't really prepare for it. They may have, you know, worked to, you know, be able to pay this one bill, but then another bill comes and they weren't expecting it, and it can really crash the whole situation. So this idea of having true cost estimations can be, in theory, very helpful. What we know, at least about in the United States, is that this has been sort of a failure. Our capacity for accurately estimating prices has been low. And our price transparency rules, so these are national rules saying that hospitals need to actually post the prices of their services, haven't been followed. And so in the United States, about only 1 in 5 NCI cancer centers are actually compliant with the federal rule to be price transparent. And what we also found is that there's huge variability in costs. So for those centers that actually posted costs, there was differences of, 1,000-fold. There was one center charging $300 for 4 field radiation to the pelvis, and there is another center charging $33,000. So obviously a huge difference, and pointing to the fact that maybe we need less price transparency and more price stability, which is, true value in healthcare. There are national initiatives that can help improve affordability in the United States. One of them is the Affordable Care Act, which essentially helped provide health insurance for low-income patients. This actually did help our patients have health insurance when they wouldn't have had it before. It also made several changes on the federal level. So like as a nation, we decided that we weren't going to, for example, exclude patients with cancer from having health insurance, which was previously allowed. So this is obviously upper level legislation. This is not without its problems. Again, this is US-based research, but it really does limit sometimes the ability for patients to go to the center that actually might provide them either the most convenient care or the specialty care that they really need. And so, it really started bringing out this concept of a narrow network, so that even with health insurance, you can't just go to the place that will treat you best. You can only go to one center, and it might be further away, or they might not be able to actually have the tools or resources to treat your cancer effectively. We know that any political or health policy change will then have politicians arguing about it. And certainly that's what we've seen, for example, in the United States with the erosion of ACA policies. So this national expansion of health insurance was then actually kind of chipped away by the next administration. And that led to patients and survivors actually losing their health insurance. It's a political football. We know that there are certain ways that we can think about improving affordability at the federal level again, so at the national aspect. So placing things like caps on out-of-pocket expenses, or allowing things like price negotiations. So, at the national level, if we're, buying X amount of drugs, can we have a lower price as negotiated from the pharmaceutical company that makes that drug? We know that there are certain ways of actually doing policy reform that can improve access to our patients and lower costs. This research is specifically looking at immigrants to the United States, showing that, for example, if you're in a situation in which you have expensive healthcare, but you have to wait until an emergency to actually receive that healthcare, the healthcare ends up being much more expensive. Again, we see this all the time when people have poor access to care. So just providing upfront health insurance for people who have costly medical expenses can actually save healthcare dollars for the nation. We know that there is a role for national advocacy. So within, kind of in whatever our capacity to present strong arguments for our patients on the national level, we should be trying to take it. And it really does help as physicians. I feel like we have really valued voices, and we can help advocate for our patients on the national stage. This is one example from last year from our ASCO Summit, where I specifically met with my, elected official and made a strong case about the role of prior authorization, which is affecting our patients' ability to get care, and then found that he actually had signed on to the bill that same day. Again, I don't know if it was related to me or not. It could have been random, but it did make me feel better. We can think about other society initiatives that can actually help improve affordability, which is, again, really tailoring down our treatments to the things that have the most value. We don't want to use things willy-nilly. So things like specialty, imaging studies or targeted therapies, we have to be making sure that we're using these expensive tools in the most evidence-based fashion. And these guidelines can actually, again, improve value, but they're not prescriptive, meaning it's an opportunity to improve the quality of care, but it's all about having a discussion with the patients about, why X, Y, or Z is indicated or not indicated. We know that for some of our patients, actually, palliative care can not just improve their quality of life, sometimes improve their survival from cancer, but it can also lower costs. This has to do with having less futile care, essentially. So things that we're not going to, for example, be saving lives, but ended up costing money and potentially causing trauma. And there is research to support that palliative care can really be a force to help mitigate financial toxicity. We can think about things of like pharmacy disruption. So how this is, again, US based, but how do we really think about pharmacy as a business and going outside of the traditional business model to lower costs for our patients? These are examples of drugs that are very expensive for our patients that are being sold for far, far cheaper directly to consumers via Cost Plus Drugs, which is a company that was founded 2 years ago to help facilitate low-cost drugs to patients. We know that, kind of what I've talked about already is primarily upstream of individuals. So I wanted to focus the last little bit on just what we can potentially do at our institutions and in our clinics. I do think of this as, from a public health standpoint of preventing financial toxicity, reducing the impact by diagnosing it early, and then softening the impact so that it causes less lasting effects. Thinking about preventing financial toxicity, education is important for both patients and providers. Thinking about, if there's a health insurance option, how to make sure we're in the right one that's affordable and that it actually pays for the services that we're going to be providing. How do we be more proactive versus reactive with our financial assistance? I certainly have found where someone was struggling with the cost of treatment and I didn't know it. And the only ways I found out was then when the person just didn't show up, which at that point, obviously we're kind of already late to try to help provide assistance. How do we improve access? So for example, maintaining patients' ability to work. Some of this is very practical, like, is there the ability for someone to get treatment closer to home? Is that viable? Is there a way of scheduling their treatment around their ability to work? For us as providers, how do we, practice the highest value of care, eliminate things that cost money but don't provide as much benefit? How do we streamline our clinics? And, for us, that could be, having a phone call instead of an in-office visit, enabling using telehealth. How do we advocate at our own center for practical solutions? So having patients meet upfront with counselors, if there's one available, can help patients understand their costs better. It can help them estimate costs better, and therefore prepare for them better. And the research shows that it helps. We know that actually improving medical education can actually inform the next generation about this problem. And that most people who have graduated from medical training say that they know someone who couldn't afford their care, but that felt that their actual education was pretty marginal or insufficient. We know that we're not trained to, address costs. So this is not part of I didn't get trained on this. And that the idea of even something like a cost conversation is even rarer than just talking about value, despite the fact that we think that we realize that we're maybe part of the problem, that maybe there are times when expensive medications are prescribed when less expensive medications were available. And we know that, again, this concept of improving education and value is so important that there's even free modules available. So Dell Medical School actually has free modules available for trainees to learn a little bit more about value in healthcare. We know that there are some potential simple practical solutions that we can help improve affordability. Having things like free food in the clinic can potentially make a difference. Having access to like Metro cards or even minimizing wait times. Parking, at least for, I live in Manhattan. It's incredible. The idea that we're charging anyone for parking is insane. But like that obviously can be a big expense. We know that actually having people get transportation when they didn't have access to transportation actually helps both the patient receive their care, and it also actually helps the healthcare system recoup the costs of that care. So it's a win-win to help provide a way of getting to the facility to the patients. So this study looked at actual rideshare. How do we get people to receive their radiation? And again, thinking about clinical trials, if you actually offset some of the travel for clinical trials, you can enroll a more diverse sample for your clinical trials if you're not getting the right patients as a representative sample. We know that telemedicine, so again, a phone call or a video call, if available, can lower costs for our patients and is sometimes appropriate. This study was specifically for people receiving radiation. And we can think about the next step. So things like technology, how do we actually help have technology enable things like financial assistance? And this program found that this app actually helped people both apply for and receive financial assistance. In this situation, it tripled the rate of someone applying for and receiving. We know that not every population is going to benefit from the same interventions. So for example, price transparency may not, affect all populations equally, and some patients are going to benefit more from something like transportation assistance. There's some value in just getting the people who are most interested in improving affordability together within one healthcare system, sitting them at the table and thinking about how do you guys work together to improve access and affordability. So that's, people from like nurse navigators to social workers to physicians to people who work in billing. And what this study found is that it actually saved, millions of dollars for thousands of patients. We know that we can potentially screen better for financial toxicity and essential needs. So yes, no checklists, or, if you have limited time, just say yes, no, are you having problems with your finances or your transportation or your housing? There is a validated screener for financial toxicity called the cost score, which is available for free. And it takes about 5 minutes for patients to fill out in the waiting room. And then we, of course, do need to start screening for things like transportation insufficiency, housing insecurity, food insecurity, that sort of thing. I think it's very helpful to think about being more proactive about those things. What we know from our own experience is that screening is feasible for our patients. We had a pretty good response rate in terms of implementing widespread screening. So about half the patients had some response to a survey. This is not all patients, right? But we were able to capture the fact that about a third of patients had some sort of screen positive, meaning that they had either food insecurity or financial concerns or both. We know that if you actually implement a screening program, that it can potentially improve financial toxicity. This is research just published in JCO at the end of last year, showing that in this trial, for those patients who had the screening arm, which was essentially, screening for financial toxicity, that it did seem to lower their financial burden. So maybe, again, by screening, we were plugging them into the resources that potentially existed. And research shows that it could potentially even improve cancer outcomes. And so in this very small study that was stymied by COVID, they found that for this very, very intense intervention, which included a navigator and a pharmacist and a social worker and one-on-one meetings with financial counselors, again, maybe not something that's feasible to all cancer centers, but for those people who did screen positive and then were referred to this kind of, intense financial navigation program, that they really did seem to do better in terms of their actual survival. We know that, potentially most of the people we see with financial toxicity are actually at the bedside, meaning that they're in our clinic and they're having problems. And so we need to be able to address them so that they have less injury from their ongoing financial toxicity. And what we know is that for people who have, cancer, most of them actually do want to have some sort of cost conversation, but sadly the minority is having it. So some people will, admit once they've, sold their property or, after they've missed appointments and you call them. But a lot of patients aren't having this conversation up front. What we know from research, again, at least based in the US, is that for people who have a cost conversation, that it can help, meaning that there can be some amount of assistance provided. I don't want to overstate the fact that we can't lower people's healthcare costs to zero, but often there's some assistance that we can provide either within our institution or, again, maybe appealing to insurance or switching to a different medication or changing the frequency of their infusions, or, having some sort of negotiation with the patient about the best care that they can get, because the compromised care, the idea that patients are going to get substandard care is a concern for some patients. But to be honest, the lack of care altogether ends up being a larger issue for people with high financial burdens. We know that from education to screening to having, financial assistance referrals as appropriate, this is, kind of the larger work within financial toxicity at the bedside. I will end up now by just highlighting that we have some potential tools to help mitigate and lower financial toxicity, but it's a real problem because it's growing, not just in the United States, but everywhere. And that, cancer outcomes are really at risk. We spend a lot of time at the bottom of the pyramid, thinking about how to, help the person immediately in our clinic. And I want to encourage everyone to start thinking upstream. How do we improve the healthcare system? How do we, redesign medicine to be more equitable and affordable? Because that's really the way we can get the best bang for our buck in terms of the future and making sure that this sort of thing doesn't happen. I will leave it here because this is certainly what I found from my own experience, that there's this idea that it's, kind of your money or your life. You either face bankruptcy or you face death. And I think, what I've seen in my own clinic and certainly what I've seen in my own life is that some patients are losing both. You can end up both emotionally and financially and bankrupt and also still die. And we're trying to move forward to a world in which that happens less and less, and hopefully never. Thank you for your attention. Happy to take any questions. If there's questions from the group, I can stop sharing.
Wow, wasn't that just awesome? So really making put your hands together again. Brilliant elucidation of the situation of financial toxicity. My colleague sitting next to me, Dr. Jima, was saying that it's amazing how everyone across board, even in the United States, and experiencing what we think is a perennial problem. How much work has gone into trying to find out how this can be mitigated. And I think a lot of it we can apply to ourselves. We want to thank you so much for this excellent presentation. And I think people will do this away notes and notes and notes. So please, can we have questions? Do we have if you want to already, we're going to think about if you have any other questions, please let me know.
Good morning. Thank you for this beautiful presentation. More or less, from what you have said, it's quite enlightening and it's wide. I'd just like to comment on your last slide. And if Dr. has also said it, that if in the US there's such an experience to find people that was choosing between death and bankruptcy, in such instances, it becomes difficult even to advise sometimes when a patient will be before you and they will be telling you their plans and what they need to do when you give them the breakdown of how much they need to spend concerning their cancer care. So, how easy does it come to then probably advise that patient to go in the line of bankruptcy, even though you know that even the debts that you are trying to run away from, they still come. It may not be the cancer, but that's the family form. So, can we then why not go on the first level of death, or should we choose bankruptcy? Thank you.
Would you like to respond?
I realized that I could only hear maybe one out of every 3 words, so I do not know if I have a good response, but I really appreciate the open dialogue, and I realize that there's very many differences in the healthcare systems, even from, again, countries that might be right next to each other. So I apologize. I realize I can't hear enough to actually appropriately understand the question.
Can you hear me now? Can you hear me now?
Yes, but
Well,
even from when you're talking, I can hear only some of the words.
I'm going to give it a shot and see. I'm going to give it a shot and try to. They were saying that problems are really resident in. So analyze the cost of treatment. We find out that the cost in itself is going to bankrupt them while they are managing an illness that was going to lead to them. The question is, should we know that even given the best that we can do, we will still profit financially to if we find out can really not afford a treatment with those bills, so we just leave them. How do we find that balance between putting a patient to try and save their life or the they die. Or should I type it out? No, I'm very sorry. We'll type it out. We'll type it out. Any other questions? You can just check on the as a message. Could you just check the task force?
Oh, someone put the question actually in the chat so I can read it, which is, should we push patients to take treatment even when we know the treatment may be financially bankrupting, and how do we find the balance? Is that accurate? Okay. That's a really good question. And I think that I think it's really a case-by-case discussion with individuals. And this is very hard when you have moved from a very paternalistic system of medicine where the patient does what the doctor tells them to how we've evolved healthcare to how, it's more of a conversation and what's called shared decision making. It's very challenging to say that it's worth it for some people to bankrupt themselves and their families, sometimes even the whole community, in order to have their treatment be affordable, right? And certainly I saw that within my own patients when I was surveying them. Patients would say, I'm not willing to sell my house or go bankrupt because I know it's going to affect my family. And so this concept of this is what we're getting you from our treatment, this is the benefit, and then this is kind of your overall prognosis. Some people actually end up making very astute decisions to not receive treatment because for someone with a widely metastatic disease, maybe it would only extend their life a couple of months, which is very hard. As someone whose husband died from cancer, I can tell you that I would have paid millions of dollars for him to live another month, and he would not. And so those decisions are quite hard. And in systems where, the additional resources to actually offset costs might be very minimal, trying to figure out what is the most efficient way of treating cancer in those situations with the resources that you have available is really essential, which is, it's not cutting corners, it's delivering the most cost-effective care for what you have available to you. And so it's, it's one fraction of radiation, it's hypofractionation, it's trying to figure out what is the safest, most effective and efficient way of treating you to get you the optimal outcome in the situation that you're in. It's incredibly challenging. And as resources go down, the options become more limited, certainly. That. And so this is that push-pull of, saying what's really worth it. But the thing is that as a doctor, I'm not the one who decides what's worth it to the patient, right? And so it should really be part of this, idea of prognosis, but also benefit of our treatments. For curable cancers, for cervical cancer, which we cure most cervical cancers, there's a really compelling argument for this is an investment in your future to get through this treatment so that then you can be a person in the future who actually is productive, who can take care of your children, who can, work a job or support your parents, the things that most patients want to do or had planned to do before they get diagnosed with cancer. I appreciate everyone's time today. Yeah. Thank you so much for inviting me.
We have more questions for you. Could you read them? Questions in the chat box.
I apologize. I think I will exit just because I can't hear the questions, but if anyone has further questions for me, please feel free to email me. I can have the organizations give out my email address. Okay. Thank you.
We appreciate that. And those really here which is the long for that we're grateful. I wish you could hear me. But please, can we just put on the words again? Please, can I ask for Dr. Miniko? You don't like beyond out of pocket payment. And a lot of times, You keep going to just 5 kilometers to like you're going through so much. Why can't you just talk to someone in your office? After all, some people don't want people to know and work because they're so afraid of the lot of income. So I expect you to ridiculous to do as the physician that the guy is interested in tracing work is all in a treatment. You really do need to understand that when to empathize, particularly in a situation from the group and reaching the result of concentration, the real time issues for people, not from, sometimes a sick person is the sole provider. It's the major provider. We try to find a solution that will make it possible. Increasing people is affordable come to the table because you want to take them to come to we are working for that country, something that is very good give their children to go to school. And it's interesting how each are these I think NLCC and Ikeja deserve a round of applause for helping us. It's amazing how I'm really a different person. You do fundraising right now, so the way to bring them to we just move forward. It's showing how much of an impact this is having, and I really hope you are having a good time on it. We're going to move on now to the next presentation. All right, absolutely. Great, Mama. Going up that news just now, it came to my head. So Mama Brachy herself, my sister and my friend, is very funny and very articulate. Oh, she has a name. I won't wrong with you. This is the knowledge. I'm so sorry, everyone, I was prepared for our Bible. We must read it because she is that awesome. Okay. So we have I was and of all the ones that they didn't send to me, they didn't send our own. But I'm going to be telling you about Dr. Ikeja herself, who is a consultant clinical, who is a radiation oncologist. She's a well-versed scholar in someone. Please put your hands to for the enlightened lady has become to talk about the NSIA-LUTH experience.
So I'll be roughly informed to cannot because it's myself not to fear. And yeah, thank you very much. That's Dr. B for you. Those are moments again. Yeah. Countries, the NLCC experience. Is a crucial component of cancer treatment and is it complete without therapy. Many that will not be required therapy is cervical cancer, and most endometrial cancer are those that are only very US cervical and component is still necessary or they are only very advanced disease and might not be able to the majority of our patient disease and we are moved from 2D where we demonstrate based on science, surface marking and the X-ray to 3D where we are seeing what we're doing. And then the 3D one. So one of those presentation, the goal is MRI. And then, okay, we have the target now for ultrasound, which is going to be the short, and this is applies to LMIC. So our and fourth of the advancement in cancer in Nigeria and not around African countries. So take a look. Thank you. Okay, so image-guided brachytherapy is highly precise. It uses advanced imaging techniques such as CT or MRI, and will give the maximum dose to your targets, and you limit toxicity and doses to the OA house. The implementation of 3D image-guided brachytherapy in NMIC is hindered by various factors, funding and sustainability, financial toxicity for patients, financial toxicity of the center too is a form of the impact. Next. So NLCC as a leading cancer center, we want to overcome most of these challenges, and we have some we are taking initiative and achievements to include the following. Infrastructure, we have invested in acquiring the necessary imaging equipment, system devices, we have a CT scanner, we have done those rates, we have machine, we have also scanner, we have the C-RAM, we use various treatment system. We have the one hospital linear accelerator. We also vital and the only center in Nigeria or South Africa that can actually boast of this. Thank you. According to most of our staff have had various training both locally and including the image-guided brachytherapy. We have IAEA fellowship training, we have NLCC fellowship training in brachytherapy, we have training also in brachytherapy, so to have fellowship training in brachytherapy and clinical oncology generally, and we have to support therapy on brachytherapy. Then we have the Johnson brachytherapy platform in conjunction with Well Cornell medicine. Standardize our practice so that we're not just looking when to control our control and to correct our control from actually go ahead to treat the patient. Somebody is the first factor, this person can be put in place for subsequent and to give maximum dose to your IBC and limit doses to the going house. What I've done is so far, this was, we were doing very well here. You didn't have the therapy machine, we're not ready to start the rest. We have this and then some hands-on demo from ourselves. So that's Dr. Judy, when we were going live, was around, she was actually, I think he came by PJ intervention there. And we also visit other centers in Nigeria. So that's he came to visit the team of the radiation oncology center visit. Dr. Balogun has been part of a success story from the beginning. Giving some extra view to brachytherapy, they do some training sessions with Professor Toxicity, our grandfather. Dr. Chika also visited and she came up from the African news there and we did for some time on experience to take additional brachytherapy with feedback from this in that aspect. That was the IAEA fellowship and cancer disease hospital. I was there with Dr. Bayo, there's people from Gombe. Yeah, Gombe, that's Dr. Mali Gombe and also here, so we get for 2 months. About they use both 3D and 3D. In Zambia. They were fortunate to know that time Professor Anuja Jiva came around to CBH, and then we had some interactions there. That's the CBH team. We can host them, Dr. Susan. That was my UNCC fellowship on PhD brachytherapy. The Cancer Centre. My trainer, Dr. Kumaya. So, other people from our team, this is variant training in the Netherlands. The medical oncology that Dr. Angela, Dr. Alabi, the medical therapist, Mr. Shaba, they will train for the treatment go on with therapy. So that's where to be able to do this validity. Programs of focus on national toxicity of oncology. So the Brachytherapy Summit last year. And so one of the takeaways for that was that they went to do that today. A lot of people came from some centers in Nigeria, and then we have some hands-on training, which I'm sure I've added to our skills. From last year. My research fellowship in NSIA-LUTH fellowship, the people in charge of the training, Dr. Perra, Dr. Mure, and I've forgotten her name, just now. Okay, so this was our brachytherapy charter that we just started. You see, NLCC and what about LMICs, we have 2 editions now, so that was our very first one. So another thing that we are trying to overcome was financing. We have innovative financing, students that explore student options. We have our program, our CEO, we had a common price at the time for patients that did both sexual and brachytherapy. So this was common. They had the the other patient is going to join the panel. She was by total health. Because you know when you have an issue, they thinking that how am I going to communicate to this patient? Never see someone woman. She was too low, she was low. Like, I don't know. This is not supposed to be sorry. Psychology. So impact so far in the past 3 to 4 years. Between 50 to 69 years of age. Talking about cervical cancer cases and Oncology, 66.1% is squamous cell, followed by adenocarcinoma, and the other is chemotherapy. This is the lower. This data, we have this one still. Before I go back again, I have to analyze it. Representation of the details of outcome and survival. Actually present 1 year no matter what will happen to people. You see the representation and eventual treatment. I need to be treated within 1 year. And we have this one. You can actually go to different places after you have told them. Then in the last 1 2 months. For the basic investigation and after the investigation of the treatment. Exactly. For those more than 12 months. They are done. Stage 2. And then when you're treating metastatic disease, you tell them that you're treating for a chronic disease. They don't manage as giving somebody like Dr. Olasile said. Outcome was mobility. So, sorry. This is supposed to be overall treatment time. So, we want it. This is 6 days. It was 56 days. Our patients are able to fall into that category. More than 60%. Completing their treatment with any times and significant for the potential and whereas only 36% don't have brachytherapy. Radiotherapy dose was 48%. Brachytherapy dose 21.15 for cervical and 17 for endometrial. We found the toxicity level to be bladder received 69.1 grade. Ideally, they can take up to 90. Rectum has 66.3 grade. Sigmoid and bowel, all of them are below the tolerance dose. And this is possible because we are doing image scanning. How much is getting to win? It is from the D90 and the CTV. Actually looking at to achieve 80.8 grade, ranging between 26 and 96, and this is comparable to desired standard guideline as between 80 and 90 grade of the IRIS-CTV. Time was coming to 75.59 days, less than 56. So it will affect our survivor 80.6%. Several factors have been highlighted. So the active side effects that we have were comparable to standard. There are our late toxicity and mortality rates. The patients that died so far all had either comorbidities or coma status to start with, and this is see you have identified. The overall of the antecedents are going to be great prediction of our overall survival that is statistically significant. Maybe as we follow them up with time, we know. And the challenge is so far. The overall treatment time, we try and work on and also goes because it's only loose than some other centers that are doing brachytherapy. So that's used for there should be a lot of synergy between radiation oncologists. So each know that we are sending the patient, we are prepared for the patient. And financial, when we discuss with our patient, the cost of treatment, then come from over for them to be told this is the cost of treatment for this. So they disappear for another 2-3 weeks looking for the money. So not to this extended more treatment. Because the science there is that are presenting for them. Yes, they will have residual disease. Our application which we have now, we have are not meant to, these ones are not meant to treat obviously disease following external dose. This is meant to be in the last 2 weeks, we have been in communication with our vendor, and we are brachytherapy and interstitial brachytherapy treatment. And the bill came to $33,000. I'm right. So I just feel percentage and report that. I've never been that has like this to get it. You are not where you are supposed to be. To your control. Okay. Yes, come and later. I cannot tell you when this started. Even know most of this. And then data, like collecting data. So before this time, where data, and training, almost that from the hands-on yesterday, we appreciate this and then we know and work to be done. Because of the people procurement, access care. And then that's the thing the W said. Not only for the patients, most of them come from far away. It's someone for yourself. These times, but that's actually need to do their work. But I spent another 1 for minimum of 2 months. I went in the hotel. It is not sometimes. So we have to work. Is how to work. I had a patient with that daughter and daughter. Now, a common pregnancy online and guide when we behavioral treatments. Of those to treatment, they had access to this care to their house. And I've been able to know that should have been able to know that to access care, that mother was there. Because I was badly hit myself. Financial toxicity is huge. And then these patients are coming in early advocating. The nurses has to be doing, what to do. Then you see the provider comes into place. So preparing for this, I lost my dad. Time code with the mortuary. So I dedicate this to him. Thank you very much.
Can you put your hands together for Dr. Adefrega. That was really an exciting presentation. And we must commend NSIA-LUTH. NSIA-LUTH for such a brilliant job. And I think in putting down, what their experience has been so far, it's pretty challenging all of us that we can aspire towards that same level of greatness. It's a difficult thing. It's a difficult thing because the financial toxicity is not just for patients, it's also for institutions. I mean, I don't know how many institutions are having challenges with getting this done, getting that done, providing this and providing that. And yet, we have never-ending demand for more and more and more to be done. It's a whole conundrum, but I'm sure that at the end of this summit, we're actually going to have a way forward. One of the questions that was dropped down from Miko, unfortunately, she couldn't read it, was that advocacy is a big part of trying to alleviate some of this cost or prevent financial toxicity from happening to our patients. But it seems that the wheels of advocacy turn rather slowly. And the question was, how can we, what tips do you have that you can use to help us actually impact our advocacy and make it more successful? Because I really do believe a lot more can be done, but maybe because of during the panel discussions and all of that, we'll be able to achieve. I think one way also is for people like NSIA-LUTH and the data that they are generating, and the data that they are generating, we can use this, to better actually advance the cause of advocacy in the country. And it's not just for us at this level. Some of things need to be made public knowledge. We need to actively show what the problems are as best as we can, so that then these things can then have impact. Because if we sit here and bemoan how things are bad, and then we do not use this brilliant data to actually advocate in a very precise and organized manner, we probably won't have that change that, oh, I should get a round of applause. I think I just gave a discussion. I'll be a topic for myself. Thank you so much. So in our presence is the very honorable and very gentle Professor Wasiu Adeyemo, who walked in, and I noticed a flurry of activity, and I'm like, power speaks for itself, really. It's actually the CMD of LUTH. That is LUTH. The day I was put my tongue between my teeth. Look, did I get it? It's like I'll start speaking phonetics. You're just look. And I think we're just going to welcome it. It's amazing to have you in our presence. And I think you walked in at a time where you could see that your center is doing a lot of good. It looks like a drop in the big ocean, the big vast ocean of what is Nigeria. But I think it should make us, and indeed you, proud that such positivity is coming out of, a small place like that, and we're making more incremental, appreciable progress, that we hope will keep rippling on through the fabric of the cancer care continuum in Nigeria. So please put your hands together as we welcome our chief host for his remarks, Professor Wasiu Adeyemo, PhD, LUTH.
You have to assist me. Sorry, actually, for other people here, you need to give me.
Oh, okay. Most of them are stepped out. So the representative of the Commission of Legal Outlets, DG has also stepped out. Our center director is Professor Mokko is Professor Mokko is other people are.
And these people, oncology from another country.
Yeah, medical physicists, nurses,
Okay.
yeah. Medical physicists. One media.
Additional colleagues. You have to say trouble from that.
Yes.
Okay, so. Good afternoon, ladies and gentlemen. Sorry, I had to get some briefings from Dr. Adeboyega because I have been invited as chief host as the LUTH part of NSIA-LUTH. So, but to make things easy for us, what we call our center is NLCC. So you don't have to bite your tongue. So NSIA-LUTH Cancer Centre. So on behalf of the entire management of Lagos University Teaching Hospital, I want to welcome you all to this program. I can see, I was not, to be honest, I was not expecting this large number, but when I enter, wow. So this is very impressive. And I can see that so many interests are represented here. I also can see very big people from LUTH. Professor Anolu is here. I can see her. Professor Okoya is here. I think they deserve a round of applause. And I also, at least immediately, I can identify my people from Ibadan. So when I say my people from Ibadan, I'm also an Ibadan man. I also graduated from UCH, and I'm in LUTH. So a round of applause for me. So I'm also aware that we have a combination of people from both public and private institutions from here, and I'm really happy to identify with this gathering. When I was quoting Dr. Adeboyega yesterday that why did you fix this for today? It's supposed to be Workers' Day. We are supposed to wake up around 12 in the afternoon or 1 p.m. So what? She now apologized and she promised that it's not going to happen again. So a round of applause for her. Thank you very much. Because ordinarily, today, I actually did not plan to come out, but this one, I'm aware that the representative of the Commission of Health has gone in absentia. Then the DG NACRAT, I was told that because it's a very important institution that was a part of this development. The CEO, NSCC, Dr. Linia Epo, I recognize you. A round of applause. I'm sure Dr. Shom will be there. I'm not seeing her, but I'm sure she's somewhere there. Dr. Abib, the COO, you are also recognized. My sister, Dr. Adeboyega, who practically dragged me to be here today. I'm very sure I've not seen her, but I know Dr. Joseph is going to be here. She'll be somewhere. And all the other doctors, radiation oncologists, radiation therapists, nurses, physicists, not only from LUTH, from all parts of the country. Sometimes ago, when we are discussing at but I must also recognize my chairman, that's Dr. Tolu Adewale. I think he also deserves a round of applause because there's no way we talk about little things that we are doing at the NSCC that we are going to talk about the management. And also, of course, I recognize Dr. Lina Hepu. About 2-3 months ago, we were having the board meeting of NSCC, and Dr. Joseph made some presentation. I was talking about financial toxicity. Honestly, to be honest with you, that was the first time I was hearing finance and toxicity together. That was the first time. And I was wondering, why is it that everything about oncology will be toxicity? External beam, toxicity. Chemotherapy, toxicity. Brachytherapy, toxicity. And she was able to now explain that it's a word that's been coined by the oncologist. But the truth of the matter is that it is what we must discuss. Just like the last speaker, the MC mentioned, when it comes to the matter of treating patients with cancer. Okay, sorry, my job is not really safety. I'm actually a vascular surgeon, so that I'm a vascular surgeon, so I also treat cancer. So I have an understanding of what you're talking about. Really, if you see a patient with cancer, and I know that many of us we are human beings. When I say human being, we also get involved in their travails. So that's why the issue of financial stability is actually very important. Now that we are aware of it, we are taking it seriously. For my little interaction with the ministry and also the presidency, I want to say one or two things to assure that the government also is actually seriously thinking about that. Let me briefly talk about NLCC. 2019 debate. Initially, it was very rough, but where we are today because of the combination of the courage and the enthusiasm of the private as represented by NSIA, and also our staff in LUTH, because we know that the public and private, we have different culture. And if you see a situation where the public and private are coming together, initially there has to be turbulence, isn't it? But we thank God that then you are able to apply what we call adaptive leadership. And today, the success is what we are seeing. I'm also happy to inform us that because of the success recorded in LUTH, the federal government has adopted a model like that of LUTH. And I'm sure many of you must have heard that the federal government is spending a lot of money. This year alone, the federal government is spending about 37.8 billion now on cancer equipment and infrastructure. I was waiting for people to talk. That's a big investment. And I'm aware that 6 institutions have been identified to benefit from that, including LUTH. Charles University Teaching Hospital, Plateau State, UNTH in Enugu, UBTH Benin, ABU Zaria, as well as Federal University Teaching Hospital Katsina, and of course, Lagos University Teaching Hospital. All the other, except LUTH, all the other 5 are going to get a combination of external beam, and some of them will also get brachytherapy. But because in LUTH, we have that already. So what we are going to have a nuclear medicine center, which will comprise of, we are going to have PET scan, we are going to have a cyclotron, radiopharmacy, and so on and so forth. Federal government is committed to doing that. You know, the money was made available some years back, maybe some 2 years back, but due to one reason or the other, we entered into some trouble. And when the new leadership of a federal minister came in, we had all of us, 6 of us, we had to go to them and appeal to them that they really needed to bail us out. What we wanted to do 2 years ago with about 20 billion, 35 billion can do it this time. So the minister, the coordinating minister of health, Professor Mohammed Ali Pati, as well as Dr. Tunja Lausa, they had to go to the president to appeal to the president, and the president understands the importance of it. And an additional 20 billion was added to the money that we have. That's why I think it about. But that is a 37.8 billion. But that was in December. Now it is more than that. And we had a meeting with the minister yesterday. So we had a meeting with the minister yesterday, and the minister also assured us that the president is to that money as a budget or on the hard issue. So we expect that in the next 12 months, at least 4 of the 6 hospitals, they are going to have a fully equipped cancer center. I'm talking about JOS, UNTH, sorry, not JOS, UNTH, UBTH, ABU area, and Federal University Teaching Hospital Katsina. But LUTH and JOS, because we are starting from the scratch, because we are going to have a building, and so that will take about 24 months. So that's, and also in terms of financial toxicity, I'm also aware that many of us must have read, and I sincerely hope that the higher will make this thing the better for us. The National Health Act, and also as well as the National Health Insurance Authority Act, also has made provision for indigent fund as well as a vulnerable fund. So, and I sincerely hope that all the implementation will start very soon, so that patients with cancer will also benefit from this. So it's important that how are we able to get to this level? It is because of conferences, workshops, and seminars like this, that at the end of it, people have put up papers and actually sent to the federal government. That's the reason why we are where we are. So once again, I want to welcome all of you. I can't mention all names, but I know that from both public and private institutions, you are welcome to Lagos. You are welcome to this program, and I sincerely hope that Dr. Lilian Epo and Dr. Abib and Dr. Adeboyega, they are taking good care of you. So thank you very much, everybody.
Well, that was really nice to hear. Thank you so much, sir. I think your centers are doing you proud, and I'm so glad that all this effort is finally materializing. And we pray for speedy expedition so that these things come to see the light of day. Because I mean, moving the way things are going, things just keep escalating, and even before the federal government will experience financial toxicity, we probably would have more centers. Thank you, sir. Thank you very much. We're so honored to have you in our midst. So please, another round of applause for the CMD of LUTH. Thank you so much, sir. We are so grateful. Thank you for honoring us with your presence. A distinguished gentleman, Dr. Uche Nwu, who just walked in right now. And as he's walking in, we're calling him to the podium. He's actually next on the list, and he has graciously said, oh, he's good to go. So please put your hands together and we'll welcome Dr. Uche Nwoku from the Federal Ministry of Health. He's going to be talking to us. It's appropriate that this is following right after the CMD, because his topic is enhancing access to cancer care, the role of the federal government. And we are just before you came in, listening to CMD talk to us about some of the things that the federal government was doing to make sure that there was better access. It's still not enough, but I mean, we were excited. I'm sure you'll throw more light since you already have some positive things you were going to say. Thank you. Welcome. Put your hands together for Dr. Uche, please. The gentleman, everybody just loves you.
Thank you so much, sir. Thank you for having me, the Chief Medical Director, and other distinguished officer. Good afternoon. I'm sorry, I'm just coming from Nairobi, just trying to hold the observer, I don't keep people waiting. I was asked to talk about what the government is doing to increase access to cancer care. And I wish I listened fully to what the assembly said. I would just skipped some things, but I'm sure it was said part of what I have on the slide. Because he is the representative of the federal government in Lagos, in LUTH. Yeah, so what we are doing as government is also being done through the institutions. And LUTH is also one of the major beneficiaries of the government intervention programs. And I'm sure more are coming. So I'm sure most of us in this room are aware of the gory statistics of cancer in Nigeria. And this is the latest release from Gobaka, where the statistics is on the increase. Before this, the annual incidence used to be around 80,000. Now it's gone up to about 127,000. And of course, the mortality, instead of going down, is also going up, close to 80,000 now. What was used to do the mortality, the annual incidence is now about the mortality for the country, which is very unfortunate. But that is also why government is also taking all the steps taken to address this. Now, the commonest cancers have not changed. there are still the breast, prostate, cervical, liver, colorectal. That's the order in which they appear in the country. But what is more worrisome is the fact that this mortality we record is as a result of what have been documented to be due to late presentations, which I also call late diagnosis, because most patients who have one pain or swelling or jota somewhere present to a healthcare worker, be it at the pharmacy shop or the general hospitals or the private hospitals. But because the diagnosis is not made early, some of them do not go to the right places to get treatment. So they eventually come to the hospitals when they're already late. Okay, so then we make diagnosis late, but not that those people present late. Some of them also, even when they are diagnosed, with our religious sentiments in the country, we want to wish it away first before going to receive care. So this accounts for why we have very high mortality in the country. But government is not resting. We understand these challenges amongst other challenges that is confronting the nation. So that is why steps were taken to develop some policy directions to address these challenges. Government also, I'm sure the same thing was talked about, the upgrade of cancer centers, which LUTH is getting a nuclear medicine facility shortly. And I'm sure he talked about that. So we also do the cancer access partnership program just to improve access, because one of the other problems with cancer care in the country is that we know it is very cancer intensive. So I'm not sure if there's anybody in this room that can confidently afford cancer care, God forbid if that person has cancer in this room. Okay, so it is something that is beyond an average man and nobody can afford it. So that is why we are looking at improving access to cancer care. So the major financing mechanisms that government has developed is the Cancer Access Partnership Program and the Cancer Health Fund. So in the area of policy, we understand that we need to address the entire continuum of cancer care. Next slide. Okay, so we need to address the entire continuum of cancer care through prevention to palliative care, to making diagnosis early, treatment, and then even up to bereavement. So government also looked at governance structures for these activities to ensure that they are sustainable. Next. So what has government done in the area of intervention to upgrade facilities? I'm sure this meeting is Brachytherapy Summit. Okay, and government started with Brachytherapy machines in 6 hospitals in 2018, 2019. And then recently 8 numbers, linear accelerators, brachytherapy machines, and then 2 nuclear medicines, 1 coming to LUTH. Okay, so these are some of the things that have been done. We know that this is far from what is needed as a country, because the professionals will tell us that you need at least 1 machine to about 1 million people. So if we want to 50 million people in Nigeria, then we need at least 250 linear accelerators. So talking about 8 or 10 or 12 or even 20 is far from what we need, but we need to start from somewhere. So what is important is that government is making steady steps to bridge that gap. So we're hoping that now we have a government that is interested in improving cancer care. We're hoping that at least on a regular basis, we need to upgrade those facilities. Okay, so the CAP program is the one that is quite unique, because we understand that some medicines are very expensive, and then you also have very limited access to quality products. And the reason is because since patients can't afford them, our hospitals hardly stock these drugs. So our patients rely on hawkers. Some rely on vendors that do not even find how it impacts on the patient. They're interested in their business. And I used to tell this story wherever I go, that as a resident doctor in Ife, a couple of times we have had to search for medicines from Lagos. Okay, ask people to help us buy medicines from patients from Lagos. And if you take some cold chain products, for instance, Figastin from Lagos, they don't care. I mean, and give transport who is probably going to Ilesha to drop in Ife. Before they get to Ibadan, the vehicle breaks down and spend another 1 or 2 hours. They fix it. Before it gets to Ife by 8 p.m., that person tells you, I'm on my way to Ilesha or to Akure. Go and pick I dropped your package with one organizer at one of those junctions there. By the time you get there, that person will tell you, I gave it to one Okada man, please call him and pick it up. This is a cold chain product that should have been properly preserved, but it's been thrown from one vehicle trunk to one Okada rider. So by the time the patient finally gets that drug, you don't know whether you are giving medicine or you are giving what you don't understand. And then that will automatically increase mortality with the side effect of that drug not removed. So sometimes there was a patient who started on medicines, the pharmacist, well-educated, high profile, walked into the hospital to start pre-medications before he can start his chemotherapy. Just asking the patient to do pre-induction. And within 2 to 3 days, the patient dies. You ask yourself, was it the cancer that killed the patient or your drug? So these are some of the challenges that prompted us to say, we need to do something to address this. Ensure we have products that are properly preserved in our facilities, not the ones the pharmacy outside stocks and gives you whatever he wants. So that's the basis for why we said we must strengthen our hospital pharmacies with these quality medicines. Now the cost is also an issue, but we also ensure that whatever that medicine would have costed outside, in the hospital has to cost at least 50% less. And that's what the CARD program is doing across the country. Now we have them in 21 hospitals, including LUTH, including FMC Lagos. So we're sure that our centers are covered, but we're also encouraging people to make use of it. It may, what save the service, what it costs the hospitals is that it reduces their own IGR, and others of them resisted it. But same this like our own, even when it was CIMAC, I have to say it, he championed this even when other people didn't want it. Same, I'm sorry if I'm saying it's a secret you don't want people to hear. He was so passionate that he will call and say, when are you coming to LUTH? Don't mind those who don't want it, I want it. As CIMAC. So by the time he became same, it was walkover for all of us. So thank you so much, sir. So that's what the program is doing, and we're hoping we have a motion order from the ministry to take this across the country so that every hospital should have access to it. Okay, so business time. So we have over 50 products now. As of last week, Merck has joined, AstraZeneca has joined, they have Pfizer, have Roche, have Johnson. So all the reputable companies you can talk about in Nigeria have put their products on the program. So that way we are sure. I mean, there are challenges. I'm not saying that it's as rosy as I'm trying to paint it. There are challenges, but I've resolved that. And it's also part of why I'm coming from. And we also try to resolve any supply chain problems that's going to hinder the program. So these are the things that characterize our medicine supplies before this program started. So we try to address this market failure cycle. Okay, where before now, as a country, we do not know what we need. We can't even quantify the number of medicines and the type of medicines we need as a country. And that also made the companies not to be able to put our markets in their access programs because they need to manufacture a certain quantity that has to meet up their what they call the minimum order quantity to be able to reduce that cost. So because we didn't have a predictable volumes, and then the market was also flooded with fake products, generics that may not do what we intended to do. Okay, so those are affecting the supply. So that's resulted in what we call a market cycle failure. And this is what the CAP program has helped us to resolve. So as we speak, we have over 4,000 patients currently on it. This part is so we're hoping that before the end of this year, every cancer patient receiving care in our public facilities should be on the program. Next. So the Cancer Health Fund is the other program that the government looked at. Even with the CAP program, it was obvious that some of the drugs are still beyond what ordinary patients can afford. So if a product that sells for about 2 million naira is now reduced by 50%, and person has to pay 1 million, how many people earn 1 million naira to be on a product that has to take every 21 days? It's also very difficult. So some people still have to sell a plot of land to access program, to access medicines on the CAP program. So it's also very challenging. So that also informed why government also took steps to establish the Cancer Health Fund. The Health Fund provides comprehensive free treatment for patients with breast, cervical, and prostate cancers because they are the commonest cancer in Nigeria. I mean, these three account for over 60% of the country's cancer burden. So public health-wise, it is safer to address about 50% of cancer burden. It will address significantly the problems of Nigeria. But I also have a good news. As last week, we were mandated to expand the research program to involve more cancers and to involve more centers. And the minister specifically said, why is LUTH not there? Who's LUTH there? Yeah, so in the next couple of weeks, LUTH is on section. Yes, so among other centers, so we are expanding to ensure that more patients are covered. Next slide. So, like I said, it's comprehensive. It covers surgery, radiotherapy, chemotherapy, and even supportive care. Even the cost of transporting for that patient, because we know that there are some patients who live where they can't even pay their transport to come and access that medicine, that free treatment. So that also covers even transportation for the patient and feeding, admission services. So it's comprehensive. Okay, so what we do is that patients is an electronic platform where people register. Maybe let me use this opportunity to clear this because there are a lot of backlash that have followed this program. You know, people condemn it and condemn what they don't understand. Now, what we did is that when a patient registers, a wallet is created for that patient, and 1 million, at least 1 million is created for that account, that wallet. Patients will not have access to that money in cash. Because what we've noticed is that when the news filtered, people registered even with fake names. They thought it's one of those government palliatives. So, and they will now expect you to pay 1 million to their accounts when they are not cancer patients. Okay, so, and when they go to the hospital, say, hey, I saw a alert that what happened, this CMD give my 1 million. Even when the CMD himself doesn't even see the one in the hospital wallet. So everything is electronic. Okay, so people now come to the media and say they register for CHFCs and they're not getting this. We tell them it is not like that. It's meant for service. So if you have a problem, go to the hospital will treat you and the hospital is paid, not you as a person. So we depend solely on the hospitals to manage this. So some of the challenges we have is because they want these hospitals to do very odd things just to give them money. So, and that is why when people say us in the social media, personally I laugh at the ignorance. You can't go to UNTH or National Hospital and they will tell you that this is not working. I don't know if you understand what I'm trying to say. Yeah, so when it comes to LUTH, you also have the same challenge. Some they will queue up, these are with fake names. I was with the head of Oncology yesterday, and she said that someone registered with Chief Daddy because they are using fake names to register. So we have the next slide. So we have over 4,000 people who have registered, but we have only about 1,119 who have been funded. The reason is because it's not just by registration, it's also by the hospital health workers confirming that this patient is a patient and is receiving care in that hospital. So people don't just register for the blues, you have to go and be seen by a doctor who sacrificed and recommend that this person is a cancer patient and requires this amount of money for treatment. So we have about 3,462 that have registered, and we have 1,091 has been funded. Each of these 1,091 patients have been given at least 1 million. Some have got that as much as 8 million. So we have, this slide is not very clear, we have about 1,095 million so far created to patients' wallets out of what we have. And incidentally, only 276 million have been spent by these hospitals because they render service and they get what they render service for. So 1.1 billion have been created to patients' wallets, but what have been used by the hospitals is 276 million. And that's why the bouncer has said, expand this to other hospitals so that this funds should be utilized. We don't, I should do it yourself. Yes. Okay, so once it's utilized, I can say it anywhere that nobody outside patients has gotten a dime from CHF since inception. I have been involved in this fund in the last 3 to 4 years, and I have not been given recharge card from CHF. I've used my own data, whatever I've done. Yes, the point I'm making is even if all I'm to say, even the SEMIs or the ministers or the PAMSEC or the direct, nobody should be accused of taking a cover. Like, it's impossible. If I open a system, I will tell you that this 276 billion that was spent, I can tell you who.
This increase in incidence is unfortunately associated with the rise in mortality rates, and this is due to several reasons, including the low income level of these countries, which result in financial toxicity, leading to a lack of access.
So we can tell you who prescribed the medicine that was used for that patient, who dispensed it, at what cost, what date and time. So everything is digital. So nothing will be lost. If you want to audit the account, we'll just give you the platform, go ahead and audit it. So when it comes to LUTH, please just, people should be ready, because someone told me at National Hospital they thought that they'll be giving them sick allowance. And nobody, and the assembly said, where will I get sick allowance from? So it's about service. And we're happy that people are getting that service. The next line. The slide is a bit long, so you will be able to see the details per hospital, the number of patients that are registered, as on the green side. So for the 6 hospitals that are already there, over 1,000 from National Hospital. So let me go closer. I can read that. Yes, 316 from Ibadan, 578 from Zaria, 291 Gombe, 1,051 from National Hospital, 491 from Benin, and 732 from UNTH. Those are the number of patients currently registered on session. Please, yeah, so, and what this has also shown is that we're able to have data that can be used for planning, to national planning. And this has not changed. So when we say as a country that we have breast cancer the commonest, this data has also confirmed that among those who have registered, breast is still the commonest, about 1,807 breast, 632 cervical, and 383 prostate. So this is also a confirmation of the statistics you have in the country. So it helps us to have a national data that can be used for national planning. And that's one of the things this has helped us to do. This next. So we have a lot of positive stories from the access initiatives of government. But what that is unique is that collaboration partnership is a key. So from the manufacturers to equipment providers to healthcare workers have collaborated to make this happen. Is the way to go. So we need to sustain it. And I invite all of you to join us as we move this forward. Thank you so much.
Wow, thank you so much, Dr. Uche. We're really proud of the federal government for these giant steps. I mean, they were not there. These things were not available 5, 6 years ago. So we are moving forward. The figures may look small, But for these ones who have had access to some of these programs, I'm sure they remain eternally grateful that their country is actually looking out for them and helping them in times of their problems. Do we have any questions for Dr. Uche? Okay, I see one hand up. Can we have the second mic given to him really quickly? Would you please come and stay with me while they fire you this question? Because I'm sure you expect it all the time. Whenever you make submissions like this, I'm sure that a lot of people are excited. Why is the number so few? How come it's not in my center? Why is it taking so long for it to get to us? And so on and so forth. Okay, let me just go to you since we're having the problem.
Thank you very much. My question is this. Is there plans to enroll private centers that treat cancers in this program? And how do you manage different costs for this cancer treatment? You know, if you go to the north, the cost for cancer treatment is different. How do you manage these different costs cutting across the nation? Thank you.
Oh, there's someone else. Is there someone else? Oh, excellent. Thank you.
Good afternoon, everyone. So my question is, this fund, is it to pay for the whole treatment or just a subsidized amount? Are you just trying to subsidize the actual amount so that, I mean, tell us what's the percentage of total amount you are going to be paying for? Thank you.
Right. Any other question? Oh, yes.
Good afternoon, everyone. My name is Ethel Olomo of Penguins Life Foundation. Okay, sir, I'm happy you talked about this CHF fund. My question is this. Talking from it, how come that when I'm a survivor anyway, when we go to the hospital, thank you. When we go to the hospital, we register for this, and if maybe to we need like 5 medications to make a chemo cocktail. But whenever we go to these hospitals, we only find one. And at the end of the day, the remaining 4, we are still paying out of our pocket. So why is government not maybe talking with all the pharmaceutical companies to supply all the medications instead of us still paying out of our pocket? Is a big challenge. And I know at least 5 persons that I referred to that CHF to register that passed because they couldn't still access the treatment. They had like 2 million in their wallet, but they couldn't access treatment because each time they go to the hospitals, the medications are not available. So what is government doing about that? Thank you.
All right, do we have, I'll take one more if there's still one. Oh, yeah, one hand, and that will be, okay, this, and those will be because we are really lagging behind with time. So I'll take you and this.
Yeah, I'm Dr. Habib. I'm Dr. Habib. I want to find out, now we have CHF, we have CAP. Are they running concurrently? Are they going to be synergized, or is one going to drop off for the other? Because like we know, any patient would prefer to have CHF where you can get everything free rather than CAP where you have to pay half price. So what are we going to do with this disparity? Thank you.
And the final question.
Good afternoon, everybody. I want to appreciate you for this lecture you have delivered. I want to know, are private centers covered under this CHF? Number 2, if a patient that has been funded along the line dies, how do you retrieve the money back?
All right, over to you, sir. Thank you so much. I'm happy that people listened. I mean, I was worried if anybody was listening to me. So some of these things were deliberately left to be discussed at this time. So private sector involvement is a question the minister also asked us. Some hospitals that are offering, that are part of CHF, don't have linear accelerators. So why don't you involve private and have linear accelerators? So that means it's a technical way of asking us to get them involved. But what happened that they were not involved, even that we didn't go beyond 6 before now, was we wanted to pilot this, to learn lessons. And I can tell you we have more than enough lessons to learn. So we can go all over if we have the funding now without fears. We have a system that has been able to show that it can be transparently managed without anybody getting into trouble with draft agencies. So we're hoping that private sector will get involved. But I won't say that categorically until we get all our hospitals that also have capacity involved. Okay, so in the next, this is May, I'm sure by the end of this May, the likes of LUTH, Medugri should get involved because they have the capacity, they can do it. And I'm also afraid that they may take over the patient of other hospitals. Yes, because those are now the reason for the low figures used by these hospitals is because they only give chemotherapy and surgery and other services. That's why that money is low. If they have capacity to do national hospital and they do good at do therapy services, they take more than half of this money. So I'm sure the likes of LUTH may open its mouth and wipe some of them. So when we get there, we'll now see how many of the private sector should also get it. So by this month, and then hopefully that may happen. Then, so is it a subsidy or is it comprehensive? If you look at my slide, I said it is comprehensive. So anything that patient requires, including feeding and transportation, is covered. You understand? So it's not a subsidy. CHF is not a subsidy. It's comprehensive for that patient. So if you require surgery, chemotherapy, radiotherapy, anything is covered. You understand? So the only one that is subsidy is a cap. And that comes to Dr. Habib's question. Now, sir, CHF and cap are complementary. None is giving way for the other. The reason is CAP helps us to negotiate the price of these metals downwards so that CHF will not be maximized. So if, like first go, sorry, I'm sorry to use a particular company's product. Any of the target therapies that is very expensive, if I to go by the real cost of that medicine and you allocate 1 million to a patient, that 1 million will not be able to buy one dose of that drug. So we need to negotiate it down through CAP so that the patient can then benefit maximally if you allocate funds to that person. So they are complementary. Yes. Then subsidy, yes, is total, it's not subsidy. Okay, so now I feel very bad to hear the story of some patients having money and not having access to drugs. I know why, and we're all involved. We all know what happened. I mean, those of us who are involved. Now, the problem is that with the Forex crisis, some of the manufacturers could not sustain supply. So, and that's why when you come, you see one medicine available, the other one not available. But we have discussed that, and like I said, within this period, we're going to ensure that supply issues is resolved. We also have taken steps to involve more manufacturers. So that if manufacturer A has problem with supply, manufacturer B should fill up that gap. The only problem we have with that is that some of our health workers have brand loyalty to some products. So if it's not that brand they want, they don't want to administer it. So if that brand is outside somewhere, they still want that person to go and get that one they want. So that's part of the problem but we are trying to see if we can get even those ones they are loyal to into the program, so that even if they are loyal to X, that X should be available. So that should be resolved very soon. So we are sorry that some patients had money and couldn't get it. Yes, I think so. For disease patients, sir, the system is so well designed that once a patient dies, the doctor knows that he or she has lost his or her patient. It prompts the hospital to retrieve that money. So every money of a disease patient is retrieved back into the pool. And that is why it is a wallet. So what we do is that we'll create a wallet for the hospital. For example, we'll create a wallet of 100 million for LUTH. And then from that LUTH wallet, we'll now create sub-wallets for the patient. So the whole money is inside the hospital wallet. So if a patient is lost, the same day recover that money into the hospital's wallet. So from that wallet, you can give to another patient. So that's what happens. So no money is lost. And like I said, no cash is given to anybody at this point of fact. And that is why we approved 1.1 billion, 1.95 billion. That money is in the wallet, is in the pool for the hospitals. But anytime the patient dies, they recover it to approve for another patient. That's what happens. So the system is designed so that it can be easily recovered. Yes, so at the beginning, it was designed only for indigent patients. So they formed a patient field on the platform, is what we designed it and we called it indigent patient selection criteria. And that's why some people who want to fill that form, and if they have a car, they will ask if they have a car, and you say yes. Those who will automatically disqualify you because they assume that you can afford your medicines. Okay, do you have your own house? How much do you earn? Those of you who earn money in dollars, if you feel it that way, the system will disqualify you. Okay, so that's what it was. But we know that there are so many professors who can't afford to their care. So we don't have to deceive ourselves. So when they get to the hospital, they now have to lie to be able to qualify, which we should encourage. So now we are going to lift that. It's going to be open for everybody. So that people don't have to lie, because we understand that all of us can't afford it. So anybody who should be able to benefit from it can benefit from it. It will also help us to place more resources into the system. I mean, the more we try to choke it, the more government goes back in appropriation. So it's going to be open for everybody this month. So at the beginning of my presentation, I said it was limited to 3 cancers who have been asked, been directed to open it to more cancers. Yes. So as you're expanding, LUTH has special flair for children. So I mean, as they come into LUTH, they're the ones who are going to be benefiting with everybody now involved. Yes. So everybody is going to be involved now. Thank you so much.
Thank you, Dr. Uche. This is the Brachytherapy Summit. I'm hoping that brachytherapy is also covered by the CHF, even though you didn't specifically mention it. And I'm sure that the answer to that is a resounding yes.
So I said the care is comprehensive. So brachytherapy, nuclear medicine, radiotherapy, targeted therapies, immunotherapy, every therapy. On cancer, yes. And let me give you a background. Like the CAP program that we call Cancer Access was designed to be chemotherapy access at the beginning. So, but when we now learn, let's say with chemotherapy, we now open it up to say all cancer care. So that means even the therapy is coming now under CAP. We have already included diagnostics. It wasn't there before, because you can't use these drugs unless you have diagnostics properly done. So chemistry is now coming into CAP for diagnostics. So every service, well, taking steps to ensure that they're all included to ensure complete package.
So thank you, Dr. Uche, for that lovely presentation. We're indeed glad that the federal government, the federal ministry, and all parastatals are being mindful of financial toxicity in the lives of our patients. We are grateful. However, we will still say to your good self, go back and tell them it's not enough. If you look at the cost of first go on CAP, Professor cannot afford CAP prices. People working in private sector may not be able to afford CAP prices. And so, yes, you are doing a lot, but it's like a drop in this very big ocean, and so we really need you to go back and, should I tell you how much first go is on CAP? So I actually opened it so that I will give you the figure. So there's still a lot to be done. And we thank you so much for the effort that you're making. And I'm really grateful that your partnership with LUTH is using a host of harvests, but please expand the centers. Port Harcourt is waiting for, sorry, I cannot wait to see you in camera. I must publicly demand from your good self that we need to be carried along, So thank you. Please put your hands together for the man that stands tall and represents our federal government. We're going very quickly. Let me invite my friend, Dr. Alabi, who is a consultant clinical and radiation oncologist in NSIA-LUTH, NLCC, according to my organ, NLCC, save me. Before I fail here again, they'll be like, where are you from? All right, so Dr. Alabi is going to be the moderator of the next session. Welcome, thank you.
Thank you, Dr. B. Good afternoon, everyone. My CMD and our wonderful professors. And let me just stand on existing protocols. Thank you, everyone, for sitting down all this while to listen to us. And we're here because of financial toxicity in cancer care. And we want to have a panel discussion now. We have some wonderful people that we want them to come up so that we can discuss together. We have powerful people here today from Ministry of Health. The DG NICRAC, which is our own cancer institute, is also around. And we want to take some steps in the right direction that will help us to help our patients do well with their treatment. So I would want to first call on our patient, Mrs. Omolara Paul Atube. So this is one of our cancer champions. She's going to tell us her journey in the cancer space and how she has been able to navigate the challenges in terms of financial toxicity. While one of the speakers, I think the keynote speaker was presenting, please, you can sit them. You're welcome. I also call on our oncologist, Dr. Folashire. Dr. Folashire is a radiation and clinical oncologist at UCH. So he works with the rural people, not some people in NLCC like Dr. Joseph, that is the high-profile patient. So we'll be seeing the real doctors that are dealing with financial toxicity. Then we'll call on Tanit. Tanit is one of the vendors for our machine. This is Polama Kojuola. Okay, she'll be representing Tanit. We need to know the cost of one machine so that we have some HOD radiotherapy here. They may need to see her before we finish, and then because we're talking of financial toxicity, she's going to sell it for them at half price so that we can get this done with. Then we have one of our big shots in the pharmaceutical industry's oncology space. Oncology drugs are very expensive. And from Blue World, Mr. Sunday Abiodun is the MD of Blue World, and he's going to be standing here to talk to us about some of these drugs and the challenges they have and how they can also help our patients and how we can navigate it. So we have some powerful people. And I've humbly asked Dr. Uche to also join us. I think we still need him because we need him to take back the message home. We're firing him some questions of things that we still feel they can do to make this space better for us. Thank you for coming. So I'll start with Mrs. Omolara Paul Atube. And when the keynote speaker spoke, you know, financial toxicity is such a terminology that has come to stay. And I remember we had an incident recently, and we had this issue of where somebody was asking us, I just heard us say financial toxicity, but like, what is this financial toxicity? People are calling it that it is the terminology that is well. Oh, that was when it occurred to us that, oh, it's like the language that is to us. Even the speaker who spoke said it's a new name for a growing problem, which is a big problem. The diagnosis has been made, treatment can be offered, but the patient cannot afford it. He just cannot afford it. He's not going to go and break the bank or something, so he just cannot afford it. We just have to find a way around it. And so I'll start with Mrs. Omolara Paul Atube. I want you to tell us of your journey in the cancer space. How were you able to finance your treatment? Okay. So just tell us how you were able to finance your treatment. How did you get money?
Thank you very much. Good afternoon, everybody. Like she said, my name is Mrs. Omolara Paul Atube. I was diagnosed in the year 2019. In fact, actually, you know, I normally tell people then that when you talk about cancer, cancer does not have a particular symptom. That's number one. And while I was diagnosed, in fact, the counseling they are doing now, it was not available then. So the first thing that comes to mind is the death sentence. In fact, that's what people say. As I was thinking of death sentence, I was thinking of how do I get myself treated? Where is the money? Where would it? In fact, you know, you don't just maybe do one diagnosis from here, they send you here, go and do this, go and do this. All these things cost money. But finally, when I got to NLCC, if I never knew, maybe what, if I call NLCC a logo session. Those of you, if there's any other patient here, because when I got there, in fact, after all the meeting my doctor, because coming from, I was sent to Ikeja Hospital, then from there I was referred to NLCC, and I specifically said I want a female doctor. Lo and behold, I met my beautiful Dr. Ikeja. She's a very lovely person to relate. In fact, she will not make you feel, even if you are a patient at all. She takes you like a sister, a friend. So going back to the question, the money is another issue. Because I asked myself, cancer, apart from it's a death sentence, where is the money? You will do chemo, they gave me the bill that day. I saw the bill and said, million. In fact, I was really thinking, was something, if I never even knew I could get help. And what is the help I'm talking about? My husband was working in a very reputable company, if not the HMO, health insurance. I don't think I'll be sitting down here today. So the HMO, the health insurance, I didn't even know they would pay for me because I never knew they could handle cancer case. But when I went to them, I said, look. The hospital said they don't deal with my HMO. Getting another story again. But thank God for the woman that I was relating with under my HMO. The woman said, don't worry. Then I talked to them. My HMO that will pay because I don't even know where I will get the money. But thank God, my HMO, okay, they need the account number. So people have account number. But my HMO is the one that will pay me. I don't have the money. So as God will have it, I never even knew when they paid the money. I was still thinking of how would I get the treatment done. Then the cashier told me, are you so name? Your HMO has paid. Thank you very much. Let me stop there.
Thank you very much. That's very good to hear. And honestly speaking, because we need to know that HMOs are now helping, and so now we, the stakeholders, should make it easy for the HMOs that want to help. We just listen to what she just said now, that the HMO said, oh, they will not collect money from them, because I remember that we had that issue at any phase of our starting our center too, but I don't think we have that problem anymore.
In fact, I became an ambassador for my HMO.
Okay, so very
because to other patients, they will say, talk to Mrs. Omonara. She know how to.
So let's see how we can help this patient. So thank you. Let's find out from Dr. Folashire's own experience with financial toxicity with your patient, especially in terms of quality of care. Okay, we want to look at quality of care, quality of products. I remember in those days when we were doing chemotherapy, let's say Nigeria was better then, we were so much insisting on drugs that were branded because we wanted to be sure of the quality of care the patients are receiving. So, but now when we see that the cost of these branded drugs is nothing to write about, anything they bring, we just take now. And so we would like you to speak in that respect. Are we trying to reduce quality of care we're giving the patient because of cost? How can we bridge this gap?
Thank you. That question is a little bit. Well, what I can say about that is that we need to get to understand our patients and the country. Really, there should be a regulatory body who should control the quality. And so we can't really put ourselves into quality control. But at the same time, we can see the diversity in the cost of the generic to the other drugs. So having to marry those, it takes us to getting to deal with patients as an individual. Because if you have to make it blanket and insist that this patient must be on something that you think is preferable, then this patient will not get anything done. And so that makes us as practicing physicians to then be able to bend front and back, at least to be able to meet that particular patient's need. We can always see the effects of the branded drugs. So what I do as a practicing physician is to give the cost for the two and ask and tell them the advantages and the disadvantages of each, and ask the patient to decide on what to go for. Because you can't insist and say you prefer this, otherwise that patient will go and never come back. And that's not what we want to achieve. So we need to be flexible in that but we must try as much as possible to let them see the advantages and the disadvantages of it. So that is the way to handle that.
Thank you, Dr. Folashmi. So I will use that now to go to Blue Wall. Mr. Sunday, in terms of these drugs that we're talking about now, there's a lot of generic in the market. It's giving me concerns. And we are no longer even sure, we don't even know what the generics are. So we just see it and we see the name and we just do. Some people bring drugs from Edumota. Some cancer patients will bring drugs from Edumota and see this is what they could afford. So they will go to where they can find the cheapest of the cheapest. We're still talking about cost. It's because of cost. Because I'm sure there's nobody who will say, oh, the branded is branded for so reasons we want you to take the branded. If they could afford it, they would go for it. And even on the CAP program, yes, we're seeing some generics there. So who is vetting this drug? How do you help me? This is your space now. You will know more about the drugs. Okay. How do you help me? Some of the drugs are even branded. You can have the one that is Turkish, the one that is UK, the one that is Germany. Okay, and you see the same drug, the same packaging, but from different places. How do you help us in making sure that we are not focusing on cost? We're still able to maintain the quality of care.
Thank you. Good afternoon, everybody. In that space, when we talk about cost, especially cost to the different players in the cancer treatments is different. Cost to the doctor is a different definition. Cost to the patient is a different definition. Cost to the pharmaceutical company is also a different definition, because from the patient angle, all that translates to cost to them is the financial aspect, the money. To the physician, the cost to an extent may not really be as important to them as to the quality of drugs or the response you are expecting. But so the pharmaceutical company, cost is actually a different ballgame, because we are more or less like in between the patient and the physician. We want to satisfy the physician by giving quality drug, and also want to satisfy the patient by giving at the most cheapest price, so to say. So it then boils down to what I call number one, conscience, then number two, ethics. It is from the conscience side, I look at it that when I see patients, I look at it that anybody can be a patient. That you're healthy today does not mean that you cannot be a patient tomorrow, or the patient is not that maybe they have done something wrong for them to become a patient. So on that side, we have to look at, okay, fine, we want to help you to reduce costs, but at the same time, we cannot afford to give you a medication that we know will not work, because that is even more costly than giving the premium brand. Because if I say a medication that will not work for 100,000, and the one that I know and I'm sure about the quality for 150,000, if the patient goes for the one of 100,000, they have both the cost on them is higher, because the results will not be the same. You have wasted money, wasted time, and also put the life at risk. So in the pharmaceutical perspective, cost to us is balancing between efficacy and price. So in doing this, because the oncology space now, we have so many players when it comes to the pharmaceutical company, and because of the access to medications now, a lot of people have access to medication. In fact, some people who do not even know anything about pharmaceutical practice and the like, because probably maybe they have tractions on the demand, like, okay, this person came today, asked for this, another person came tomorrow, asked for, they don't even know what the drug is doing, they don't know they just like, okay, probably maybe they have a contact somewhere and they just say, can you get me this? Okay, if it's for this, we have, because the, let me say the pharmaceutical space, when it comes to maybe importation, is actually what I call it's a variety. What I call the Jankara market. You can get anything. It's just like you going to the market to buy pepper. You can get the fresh one, you can get the almost rotten, you can get the rotten one. So it depends on what you are requesting for. So if an importer is saying, okay, I want the cheapest to him at that point is the cost. He doesn't want to know if it is effective or not. So in that space, what I would advise, as you said, that how do we get quality, and and so I think I would only advise the physician to advise the patient in dealing with renowned and trusted pharmaceutical companies and brands also. I think Dr. Uchi was speaking the other time, you were saying that some doctors are kind of brand specific. You'll be brand specific when you have used some brands on your patients and what you see is nothing to write home about. You are not happy about it. So you want to specifically say, okay, give me this brand I'm used to and I've seen the result and has been working over the year. It may not be the branded one, it may be generic, but because generic is in different categories. We have the premium, we have, so it's just in that space. So when you're talking about generic is generic in general, but generic for the pharmaceutical companies, we know the categories of generic. The fact that a drug is coming from, say, Turkey, does not mean that is substandard. But it does not mean that in Turkey you cannot get the premium one and you cannot get the also the non-effective one. So it boils down to conscience and ethics for us.
We will take that as a take home today, conscience and ethics in deciding what to use for the patient while we're considering the cost as well. Thank you. Dr. Uche, so there's this thing about the health insurance scheme now. We're happy that some HMOs are beginning to, is there a way the government can partner with some HMOs to increase more of their help for cancer service? Because what the ministry is currently doing is more of drugs. And believe you me, it's not only drugs that is expensive for the patient. They have to do surgery, do radiotherapy, do so many of other things. So I'm aware of some that do investigations for them, MRI, CT, and what have you. Is there any way the ministry can help? And then there's, so two questions I'm going to take for that when it comes to the insurance. I think I was on a meeting, one of the clinical trial meeting, and there was a discussion on patients can register for health insurance, the national health insurance. It's 1 million, and then they will have free access to all cancer care. I don't know if you have any information on that. Okay, so these two things, can you help us shed light on how we can help our patients?
Thank you so much. The issue with health insurance is a government agency, NHIA, and then the states are also coming up with various state health insurance. So they come with different packages. Okay, so I'm not aware of this 1 million thing, but it may not be out of place because I'm also aware that some pharma companies are partnering with the NHIA to promote certain packages. Okay, so where they do what they call radio or whatever they call it by different companies. So do this, get this drug free, do that, and all of that. So that is happening. But as government, our primary interest is to ensure health coverage and coverage for patients. And for me, especially cancers, because that's my own space. Okay, so, but the problem with NHIA Act is that certain things need to be put in place before certain packages are put generally on the program. Okay, so and that was why last week I had to go and to defend certain drugs with the Essential Medicine List Committee because I was actually somewhere in the East when they called me that my staff that went to defend it at the shops down. I had to fly out to Abuja just to attend that meeting to present. Because to the committee, they are looking at drugs that are in popular demand. That's their own intent. And I told them that for that one leukemia patient that probably requires drug X, even if it's the only one, it is popular for that patient. So you should look at what's our priority to the country. And right now, cancer is our priority. So you should list every single medicine needed for cancer care. So until those medicines enter the essential medicines, NHIA will not by law enlist them as part of what their health care package should cover. So I need to start from that level to defend it before we get to NHIA to make sure they include all of that. That's for medicines. So other services as well, depending on the cost, because the premium people pay is still 750 naira, I'm not sure has increased. So if people pay 750 naira per month for health insurance, now, unless we want to deceive ourselves, that may not be enough. I'm not defending NHIA, but I've taken steps personally to engage them to their CEO to say, why don't you include everything cancer? But for me, everything cancer should be on health insurance, because we talk like this, we listen like this, we'll take it back to government. So for me, they should list it, but they want to defend why certain things are not done the way we want it. So until they're able to capture enough number to be able to foot such bills, then it will be difficult for them to include. That's what they tell us. But we're also happy with the new NHIA Act that has made health insurance compulsory. So, and they've operationalized it. So as soon as they're able to enroll everybody, now the premium they're going to get from everybody should be enough to cater to those that need those specific services. I think that's where they want to leverage on to raise funds. They also now have in their act the vulnerable group fund, which has also been cash backed this year, this year's budget. So I'm sure with that, they'll be able to also render such services to people. So these are the things that are happening with NHIA, and I'm hoping that they now have a new CEO who I'm also aware of is also doing a lot of things to ensure that they cover everybody and cover every service. But I know that it's not something that will happen overnight. It will take time to be able to raise funding to do what they want to do.
Okay, thank you, sir. We are hopeful that with you and having gone with us in this journey in the cancer space, we're hopeful that you'll still be able to put some voice out there for our patients with the NHIA so that they can get so many of these things upcoming for our patients, especially surgery, investigations, and radiotherapy. We don't want them to only be, even the drugs, we know we're still shouting and saying it's still expensive. Still many of them can't afford it. We just want things to be better for them. So we just keep pushing. Thank you. So I'll talk to the TANIT representative here, Mrs. Makojola. So I'm sure that with the dollar increase and everything, anybody that wants to buy a radiotherapy machine now is going to have to spend a lot. And this is us coming from saying that we're having challenges getting machines in all the centers, even with the effort that the Ministry of Health is playing. So, but this concern that I have, which I want us to talk about, is giving us machines that are complete. So complete meaning that I remember some years back that when we had one of the old machines then that, and it didn't have some components. And what we were told then was it was what our money could buy that we were given. So because I know that some of these machines comes with different parts and can be removed depending on your money. I don't know if that is part of what TANIT is aware. And all these things too comes to financial toxicity. The government cannot afford this, they can only afford this. And it doesn't help us to give the quality of care that we expect for the patient. How can we navigate around this?
Thank you very much. So you are correct that these machines have components, and depending on the kind of treatment you want to give, this will determine the kind of components that should come with the machine. Now, we understand that in terms of, first of all, that these things are paid in dollars, you pay in dollars. And we know that in terms of availability of dollar and fluctuation in the exchange rates, it could be very costly for the Nigerian populace. However, part of what we have provided as a solution is to look at our clients' cash flow and financial model and give a payment plan. So we are open to that. So that is one way. Another way, because we're an innovative company that always likes to look for ways to support our clients, we have recently developed this PPP, public-private partnership initiative. We have implemented one in the East with one of the teaching hospitals there, whereby we bring in a private partner who is ready to fund this cancer treatment, bring in the machine, and also operate the treatment facility. However, because it's the teaching hospitals facility, there is a operating model that is discussed with the institution.
this gives the opportunity for the institution not to have to pay for the machine itself. And just because we're using a facility, then we still get some form of returns and all of that. So they have extra money to support patients if they need to. They are not burdened by it. So we are always looking for ways. I mean, yes, there are other components, but we are open to giving you this over a period of time of payback.
Thank you very much. At least we have evidence of that with our project we have with you, even though it's PPP. And we're hoping that you'll be able to replicate what you have with us in other centers and give them complete machines. That we have 3D, that we have all the multi-leaf colliminators. So everything complete. And it's also good to know that there are payment plans that can be put in place. I'm sure some people can tap into this.
As you know, when we installed your machine, this was between 2019, 2020, then the latest was the Brachy, which was in 2022. There's a lot that we've, in terms of feedback, and we put that into how we approach our clients now and how we make things in terms of cost less burdensome for everyone.
Thank you. So these are the things we're saying about overcoming barriers. Okay, we keep having challenges, we keep having barriers, and when we identify these barriers, we're able to find solutions, okay, to put in place to make sure that they are no longer there. We have some centers that they have the machines that are up to date. That's one thing that we should also talk about, that are up to date. And so because of that, we have patients who have to travel all the way from the north. I think I have a lot of Zaria patients now who have to travel all the way, see, they have to leave their businesses or their work, come down, stay in hotels. These are some of the barriers we're having, but if we have machines in every geopolitical zone, and I think we'll be able to reduce some of these issues. So I'm sure you will get more customers today. Now you have said there's a payment plan. Okay, so as a way of winding up, I'll be stopping with Dr. Folashire to still talk to us about, we're talking about 70% of the world having no MRI assets. That's one of the presenters, Dr. Ye spoke about. And so we're still having challenges in terms of, so this is not only related to even cost. Or I remember one of your patients who in Ibadan needed to do MRI and was having challenge and couldn't do MRI for weeks. So, and the patient were thinking of sending the patient to Lagos. So all these things are cost effective. Are there ways in which we can go around this? Now we're talking of enhancing access to treatment, brachytherapy service, imaging, other things to reduce cost for the patient. Are there ways in which we go about it, and how did you help your patients? Especially that one that I just mentioned.
Well, the way to go is partnership with private sector, because once if we are able to encourage private investment in our institutions, most of this in Nigeria, I see that we have a lot of people, even that have money, that they don't know what to do about it. But the problem is that they want quick return. And so, but once we have people that we can convince to be able to cite this, and thank God the CMD is also here, and I'm sure he is a person that is open to such things. Most institutional admins, they are open to private partnership. And so that's the way to go. That's number one. Number two is also for government policy. I don't understand some things, but as you go higher in management, you start to see some things. For example, in usage, in our own department, we've identified in a company that is ready to bring our machine since almost 2 years now, if not. But government needs to, there's a process for them to get it to usage. And it has delayed for this long. And when I find out, I see that is just a part of, we call it bureaucracy, but it's, what do they call it now? Government, this is to be able to get to the protocol that you have to go through to be able to get. I need to choose my word.
Government is here.
We have government here. So, because I can't understand, when you have identified somebody that is willing to bring something and they have set it and we are like, well, about 3 weeks ago, they called me for a meeting, and when we got to the meeting, I thought they were to tell us that the machine is there, but it was to get a middleman that would be between us, the manufacturer, and the business. Why do we need a middleman when we have somebody already that we have identified? So, but these are part of what government policies, which we think, I as a person would think we need to, because that will also increase the cost from what I have identified. Why do you need a middleman? That middleman definitely will be paid for doing the middle interaction. And so that will increase the cost of the delivery. So these are things that needs to be looked into that will help. So PPP, insurance, government policies needs to be reviewed to be able to get us to reduce financial toxicity. So that's what I think.
Thank you, Dr. Holashe. Maybe I'll just say that after maybe you see our CMD, we have 1 or 2 things to say to help you, to enlighten you, to tell you how we got there. Okay, so I'll just take one question from the audience because our time is up. Just one person to ask.
Thank you very much. On this financial toxicity, I've noticed we have not mentioned the area of government intervention in one, maybe creating government-owned pharmaceutical company that will specifically produce these cancer drugs. We have not mentioned that. 2, government intervention in ensuring that the import duty on some specific cancer drugs that are imported either removed or reduced. I don't know if the government is looking at it from that end. And possibly, those that produce within the country, is there any way the government is actually subsidizing the selling price? I mean, kind of to actually take care of this financial toxicity. Thank you.
The moment she had government, she just give the microphone. Okay.
Not necessarily related to what we said, but I think there's some perspective that we need to get so that we'll be going back and forth, 200 kilometers forward and 1,000 kilometers backward. And I think we also need to realize this, that if you look at our system, no, you may not like it, but that's the reality. We are capitalist in nature, that's the truth. Whether we want to like it or we don't want to. If you look at this government, the direction the government is going, we have many cancer centers in Nigeria. How many of them are being run effectively? I can mention 2, one in the north, one in the south. They are not able to make any headway because the management is complex. So the question is that cancer diagnosis, talking about radiology, and also cancer management, talking about teletherapy, brachytherapy. I think the model, and that's the direction the government is going. But some people will say, okay, what about those who cannot afford it? That's why we are talking about insurance. You're talking about those who cannot afford it, like indigent, like that. There is no hospital in Nigeria, public hospital, that can handle MRI and CT scan. That's the truth. If it is not PPP, you're going to run into trouble. You are going to run into serious trouble. That's the truth. So the question is that government policy allows it. Why don't you bring it in? And those who cannot afford it, let government set out a program for them to be helped. Rather than, you know, in Nigeria, let me give an example to let you know, in LUTH, my experience, we have 3 categories of patients. And maybe you say patient relation, because whether patient pay or relation pay, somebody pays. 3 categories. You have 30%, extreme 30%, extreme 30%, and the problematic 40%. The 30% are those, or a little bit less, are those who have money, access our facility, and they are ready to pay. That's 30%. The extreme 30% are those, no matter, even if you do them, they don't have money. But the government does not allow us to reject them. We still have to take care of them and hope that somehow they will pay. The problematic 40% are those who have money. They don't want to pay unless you now squeeze them. Those are the problems. So the question is this attitude of it is government. Healthcare is a serious matter. Government is doing a lot in terms of putting infrastructure. But the question in terms of management, and let me, the hospitals I mentioned, 5+1, that's LUTH, that the government is serious about infrastructure related to cancer. They are using the model of NSIA-LUTH Cancer Centre. It's going to be built by government, quite all right. Well, it's going to be managed by NSIA. I may go to say that there is no way to have handled our cancer center without involvement NSIA. Take it or leave it. And that is the direction we need to go. Thank you very much, John.
I'm not sure I still need to speak, but if I may respond to your questions, there are things we need to understand that the health sector is not isolated from the problems in the country. So, and the more we look at it that way, the more we take it out of perspective. And then there are also things that other sectors the health sector depends on to be able to do what they can do. Manufacturing is not solely a health sector problem, even though it's impinging on our being able to have access to medicines. But manufacturing is not, I mean, if they set up a plant, the Minister of Health may not have business with that plant. His own business is that is there medicines coming out from it. But the other sectors that should deal with it are the ones that we should be talking to. And then is it something that is within them 100%? As long as there's no steady power supply, you cannot talk about any manufacturing anywhere. So these are things that in power sector, even though it impacts on health, but is 100% outside the purview of the health sector. And yet, we depend on, and I'm happy that, I don't know whether it's still there, but when I came to do the last time, the assembly was telling me that they have 24 hours light because they have the 2PP, whatever program you have has given you light. That's for LUTH. How many other hospitals in the country have that kind of opportunity? So that means for you to run your hospital, you still depend on power. And many of them will tell you that they spend almost 70% of their IGR for, I mean, other diesel or to pay. So these are things that are complex, you know. So it's not something that to say government should do. Government is also will also do their own. And I want to follow you to also challenge government. We're all citizens. Yes. No, yeah. And then when I say challenge, we also challenge ourselves because we also.
That's why we're challenging to be our voice.
Yeah. So it's something that can be done in collaboration. And then Dr. Flash, you see, the government, I'm sorry, students, asked a question about some of the bureaucracies, in doing programs with PPP. The question is, if he's working in LUTH, he's working in UNTH, he talked about UNTH, PPP. So why won't he work in Ibadan? So the question is, what's the problem with Ibadan?
That's what I said.
Understand? So, and I wouldn't go beyond that.
Yeah.
So when you know that things are working in other places, then you look at their model, look at how do they go about it. If you don't know what about it, if you need to talk to anybody, talk to that person. Because now, a number of times when government puts some policy mechanisms in place, most of the time, those policies are thought out. People will sit down, think about it front and back before they implement it. And people who don't understand it will criticize it. They won't know what went into that for them to come up with that policy. So there must be a reason why government says, if you do PPP, don't do it without approval, because people have abused it. People also want to leave it on it to pursue their private businesses. So you need to put those things in place to checkmate corruption. So these are things that when we do, we have to follow some of those procedures. Now, a couple of times when you want to do something and you apply, the best thing to do is to just go by the first person, just follow whatever steps you asked to follow. A number of times you will make mistakes. So you can take it further and see if it's from the ministry, I can volunteer to follow up from that end. But if it's not from the ministry, look inward and see what's happening. Thank you.
Okay, thank you, Dr. Uche. I've been told that Professor Duro Sinienti is online. We introduced you earlier on, and that he wants to make a contribution. Okay, his response is, okay, Dr. Uche, I appreciate your contribution regarding the onset of the CHF, which originally was called Catastrophic Health Fund and later Cancer Health Fund. I wish you will acknowledge Stephen as being responsible for the start of the program following its cancer summit in Abuja some years ago.
I want to publicly acknowledge Prof. I mean, if I knew he was here, when I mentioned Sandy, I would have reached protocol to mention him first. Even though Sandy is a government official, because he has also personally done so much for the cancer space in the country. Yeah. And it deserves.
Thank you.
Yes, okay.
We appreciate you.
And then I will ask you to admit that SafeChef came to be from Siphon meeting. There was a conference they called and invited Dr. Lumine, a World Bank, to speak. And Senator Oteji Osho was in that meeting. And as a passionate senator he was at the time, he asked, what do we do? That's how SafeChef started. Okay, and Prof, this should be on records. I want to acknowledge and appreciate what you and your team did. And the Senator Oteji Osho, to be frank, I don't know him personally, I've never met him before, but I was told that's how it started.
Prof, we appreciate you.
Thank you so much, Prof.
We appreciate you.
Thank you. And the way to pay Prof is to bring this home. I'm sure he may not be comfortable that all this while he has not been close to his own domain. So, Prof, like I said earlier, CHF is not coming to LUTH, which is your own home. I mean, you should be able to say, yes, what we started, my own people are benefiting. Your people are actually all cancer patients anyways. Right. But because
Thank you, Dr. Uche. Thank you, everyone. We want to especially thank every one of our panelists, Dr. Olashire, Dr. Uche, Mokojola, our wonderful champion patient, and Blue World. Thank you for spending time on the podium to enlighten us and to address the barriers. And we will all keep pushing forward to make sure that we bring these barriers down. Thank you, everyone.
Thank you, Dr. Alabi, for moderating that session, and thank you. I mean, the questions are limitless and endless. There's always a divergent array of opinions, really, on how best to move this forward. But I think at least, for what it is worth, we've been able to nibble at the edges of it, and we've been able to set the ball rolling. We hope it gathers momentum And we hope at the end of this summit, some of the statements that are released from this would actually also help to further assure that we can actually reduce financial toxicity when it comes to cancer care. Thank you, everyone, and thank you, CMD, for throwing some light into that. And I'm sure that Ibadan is going to get a lot of help from you. Very, very quickly, and I really do have to apologize to our international faculty who have been waiting online to have their say. The BVGH, which is BioVenture Global Health team, represented by Kathy Graf. I'm hoping I'm pronouncing that right, as well as Dr. Yubi, have been waiting online, and we've far stretched them by going beyond the time that we expected that they'll come on. I'll read the abridged bio for both of them. And while we're apologizing for keeping you for so long ahead of beyond the time you were expected, we're also pleading with you to please consider reducing the duration of the presentation, which you have already made to about 20 minutes, if you will please respectfully indulge us, kindly indulge us as we ask you respectfully. So Kathy Graf and Dr. Yubi Zakaria Ahmed are with BioVenture Global Health, and they are going to be talking to us about brachytherapy startups in LMICs. Kathy Graf is the Vice President programs at BVGH and BioVentures for Global Health, where she develops new program strategies and leads the African Access Initiative, an African Consortium for Cancer Clinical Trials Program, AC3T. Dr. Yubi Zakaria Ahmed is the radiation oncologist at the University Hospital of Tangier, Morocco. He's highly experienced radiation oncologist specializing in urological cancers, and the bio is pretty impressive, pretty extensive, and it just shows us how worthy we are. I mean, how worthy our speakers are, and how lucky we have them to address us. Kathy Graf will go first. Apologies if I'm not pronouncing that name exactly as it should be pronounced. And then Dr. Yubi Zakaria Ahmed will come in next. So if you are ready for us, you may please proceed. And thank you for your patience, and thank you for being so gracious.
Thank you very much, and it's a pleasure to be here today, and you pronounced my name perfectly, so thank you. Let's see, I will go ahead and share my screen. Perfect. So just as a brief introduction to our organization, so I represent BioVentures for Global Health, or BVGH, and we're a nonprofit